careful as well to who you're in these chat groups with, because you don't always know who these people are. It's some people sometimes say they're people that they're not, and you end up in a position where you're you become quite vulnerable, and the people in the chat rooms are taking advantage of people and they want to get money out of them, so they ask for pictures, they ask them to do things, and they want the money at the end of the day. And this is how, and I've explained this is how they earn their money. It's this is their job, so that they go into these chat groups looking for people who will, it might be vulnerable, and sometimes people on social media, they might be lonely, they might want friendship, and these people who are pretending to be your friends are not really your friends. So you just be very, very careful that you always know who you're talking to.
Excellent.
Okay.
Thanks, Sharon. Thank you so much.
Problem. Okay.
I think whatever me, Haim, or Anamika speak, it's more from the textbook or our experience. But as a parent, what you share, it's very, very valuable. And I don't think I read any book, I will learn this much. Thank you so much for sharing your experience.
Okay, no problem.
And I think you joined from Cornwall, and in your holiday, and when I approached you, you openly admitted that I'll come and share.
Yes, yes.
You're really thankful.
Okay, no, that's fine. I'm glad I can help. If I can help somebody, one person even, that's, you know, what we can do. Okay. I hope it goes well. All right. Thank you.
Thank you. Stay there.
Bye.
So I like to have a quick run through my slide, and particularly okay, that's me. And I just want to say how common this is. This is in 2013. If you look into the current statistics, I think I would say at least 1 in 3 kids will be using mobile devices every day. And what happened, I think, if the children, young children under age 3, it's a quite direct link. If they use more screen time, the speech and language will be delayed. That is obvious one. I think the thing which I like, I think again, but having said that, in pandemic, we used more screen time, but I want to highlight this one. But you may ask in your school, or even in my mental health team or physical health team, we did a lot of clinic and teaching, everything via screen time. But I would say we do the screen time like a good screen time, bad screen time. The good screen time is more like a meaningful connection to the children. The teacher do a lot of teaching on screen, they interact with the kids through asking questions, they're giving prompt, and then ask children to think and solve the problem, live demonstration, creativity. So this is more like engagement, a meaningful connection between the screen and yourself. So we are not, I think that's like a good screen time. What we focused here is like a bad screen time where you sit on the being sedentary, sit in front of the computer or PS4, Xbox, hours and hours, and invite all sort of social problem, mental health problem, physical health problem. That's what we kind of focused. But of course, you can see the graph, how screen time has been massively increased during the pandemic. And then I think this is very, you can ask yourself how many devices in your home is connected to the internet. I think I put only small list. You can add another 10 or 15 to every household. There are like so many devices we connect each day. And then how addictive these devices and which one are more addictive. I think the most addictive devices are the ones that feed more powerful drug, which we call dopamine. Dopamine is a chemical messenger we all have. And what it can do, dopamine is quite critical or essential for our well-being, learning, mood, motivation, habit, exploring, sleep. But it is quite essential, the dopamine. But what happens if the dopamine level goes high, you may feel more increased feeling of pleasure, increase cognitive acuity, provide high energy, more level of learning, increase motivation, increase productivity. It may sound pretty right, but actually when I will explain a different way. The ADHD is one of the conditions where children have hyperactivity, impulsivity, and attention problem. And those children, they don't have enough dopamine. So you're giving dopamine like a treatment. And then it will improve the same effect like motivation, learning, everything will improve. But what happened, the child who's already have a normal dopamine, if the device is making your brain to fire more dopamine, it can create anxiety, agitation, self-harm, all sort of problem. And screen time, I think this all I learned from the children I see. They call fubbing, technoference, zombie. And I think it's like you use the mobile phone and you ignore the social interaction with the people around you. And then again, we all have a two home. The second home is like a virtual home where you live, you laugh, love, cry, and work. But essentially, everybody have a second home. But slowly, people are spending more time on the virtual home rather than your real home. That's really worrying as well. And then this is the fact, actually. The time we spend on screen is at the expense of an interaction in your real home. That self-explanation, actually. Every third of our screen time while eating and family friends, which already focused on. 50% of wander along the street looking down at a virtual home. 11% of say we actually cross the road while looking into the virtual home. Third of us wake up and within 5 minutes, you look for a smartphone. I think most of us will do that every day. And I think it's not the gadget's problem. I think it's how we relate, how the behavior from us towards the problem. That is the more thing, actually. We should stop looking down. We should start looking up. A small video, probably you may have seen already. I just want to focus through this one. Audio there. Yes. My take-home message: switch off all the notification in your mobile phone. Stop looking down, look up. If you take that message, that'll be really great from me. Any questions? Anamika, do you want to do the slides quickly, or what do you reckon?
Only if there is some time. Yeah, okay. Yeah. Thank you. Shall we just do the... Right, so very, very quick. I think it may be a bit of a repetition, but a few extra points coming from an eye doctor. So there is a new terminology which has recently been, which has recently come about, called computer vision syndrome. It's also called digital eye strain. Now, the picture on your right, what you see, it looks pretty familiar, doesn't it? There are 3 kids sitting in the same room, but they're all looking at the screen. And some of the common things that I hear from children who come to my clinic is that their eyes feel tired or they feel dry, sometimes complain of headaches, and the vision is not very clear after you have looked at the screen for some time. Now, that is more common. But some of the things which I have recently seen, especially during the lockdown period, and which not many people may be aware about, is that suddenly these children can develop squints. You know, when your eyes turn inwards, you become cross-eyed. And that means you start seeing double because your eyes are not straight, and leading to loss of balance, falls. And it's just not a nice thing, isn't it, to see double. And the other thing which we know, that increased use of screen time can make you more short-sighted. So again, nothing wrong with that. People can look very cool in a nice pair of glasses, but you know, there are problems with being short-sighted, especially if you become increasingly more short-sighted, your glasses become thicker. So just to come to becoming cross-eyed. So in my own clinic, I saw a few children who came in with this particular problem, and they needed either squint surgery because no amount of eye drops made their eyes straighter, or they needed, you know, other more invasive treatment. So not something which is very benign, isn't it? You know, excess use of screen time. And the second thing about becoming short-sighted, if you are very short-sighted just because you're using your computer and you know, tablets a lot of time, then you can't focus very well at night. So, if it is a big dark place, you won't be able to see very clearly. But even more important than that, and something which is more serious, is that people or children who are quite short-sighted can develop sight-threatening conditions like retinal detachment. That needs, it's a major, big operation on your eyes to restore your sight. Yeah. So next slide, please.
I think we have just got a minute left to go.
Okay, that's fine.
Any messages from you, Anamika?
Just one thing, that there is a rule called 20-20-20 rule. If you can remember, I know that Hema talked about a few rules, but if you can remember to look away from your screen every 20 minutes, just for 20 seconds, it's not a lot, to look at something which is about 20 feet or 6 meters away. So if you can remember that, I think that will be a fantastic thing. And then of course, outdoor activities is a great thing. Thank you very much.
Thank you so much, everybody, for joining. So we're going to finish on time. We're not going to delay. And so as I said, take it in the right sense, balance it out, and have a right balance for both your mind and your body. Thank you so much, everybody, for joining.
Thank you.
Any questions can be posted in the chat box and we'll try and answer it. Thank you all for your support, and please donate generously to RISE Foundation for a good cause.
Hello, everyone. Can you hear me? Yep. Okay. Hi, Simon. Hi, Shri.
Hi, Dinesh.
Welcome everyone to RISE-24, second year going successfully. I'm sure you would have enjoyed healthy cooking, losing your heart, and if you've lost your heart, mending your heart as well with some cycling. Paul said, I'm sure next talk, the topic itself will take our heart away. We've got Captain Simon Murphy, who has got years of experience and about, if I'm not wrong, did he say 11,000 hours of flying experience in a major UK with major UK airlines. I'm proud to introduce Mr. Murphy, who will be talking about how to take some big birds into the air and keep us engaged for the next hour. Simon, thank you. You can go ahead.
Thank you very much, Dinesh. Can everybody hear me, first of all?
Yes, we can.
Good. Excellent. Yeah. Well, thank you very much for the intro, Dinesh. Well, very good evening, ladies and gentlemen, boys and girls, and a very warm welcome aboard this virtual flight to Ibiza. I'm going to, first of all, say thank you very much for having me this evening. It's fantastic what RISE is doing. It was really an honour to support you with this. A 24-hour video webinar is no mean feat. So well done to everyone so far, and good luck to all those coming up as well. So this evening, I'm going to spend a little bit of time chatting about how we get aeroplanes flying at the start of the day. There's quite a lot goes on behind the scenes that perhaps even the most frequent passengers don't actually get to see. So I'm going to share some of that info. I'm going to just try and share a presentation, hopefully. That will come up. It's in small screen. Can you see the presentation? Should be an aeroplane. Yeah, perfect. Excellent. So I'll run it in there. Little bit about myself. As Dinesh says, I've been flying for quite a while now, flying commercially for 18 years. Actually flying light aircraft for around 25 years, so quite a long time. Got around 11,000 hours, a little bit more than that. And some of the aeroplanes that I've been flying, the Boeing 757, that's what I first started on. So that carries 235 passengers. Very shortly after, I flew then the 767, and we could actually fly these two aeroplanes together. It's all on the same license. So one day you could be in a 757, the next day you could be in a 767. The 767, the maximum configuration we had was 344 passengers. I flew those for about 9 years. Then I flew the 737, which is a little bit smaller. It's about 190 passengers. I flew that for 1 year before then moving on to Boeing's 787 Dreamliner. It was brand new in the UK around about 8 years ago now, and I went onto it we had it for about a year in the company, and then I got opportunity to fly that. Again, our biggest version of that is carrying around 360 passengers. And at the moment, I'm back on the 737 again now, so I'm flying just short haul. And so that's probably as far as Egypt, North Africa, the Canaries, Turkey, that kind of region, and everywhere in between. So moving on to what happens when. So Flight Operations Center. This is a central head office place, and I've got there T-4 hours. So that's 4 hours before departure. We've got a team of very highly skilled people who organize our flight plans. So what that involves is looking at weather. That's very important for our departure airport, en route, and also our arrival airport. They're also going to be looking at, it's called NOTAMs, it's Notice to Airmen, and that's basically written text giving you information on various things. So that could be, for instance, a runway is closed. They could be resurfacing it. They could be installing new lighting, or some of our navigational aids might be off the air and they're being repaired. So any information that will be useful to pilots and operators, they are published in NOTAMs. So again, the flight ops department will be checking all the NOTAMs and making sure there's going to be nothing that's going to affect that flight. Once they've done all that, we've got a very complex computer system which analyzes the routing from A to B. And that looks at the wind. Tailwinds are good because they push us along. Headwinds are bad because they slow us down. And they're going to look at actual congestion within the airspace. So London airspace is typically very busy. And they're going to look at the weather, and the computer system creates a route from A to B that is going to be most fuel efficient and time efficient. So once they've done that, if I go on to the next slide, there's just a little picture. In the air, there are imaginary motorways. So we have to comply with these motorways, and they'll help you get from A to B. So it's very rare we actually fly in a straight line. So there are going to be turns left and right going between. Traditionally, navigation aids, they were ground-based, but a lot of it is now done on GPS. It's more accurate and actually cheaper. So the navigational department, the flight ops department are going to compile this all about 4 hours prior to departure. A little bit sooner, after they've done their work, our maintenance team, they're down in the airport. They're going to be looking at the aircraft themselves. They have to have it's called a 48-hour check. We actually do it every day. And that covers a lot of things. It's very basically an MOT for that aeroplane that is done every single day. So they check the oil in the engines, they'll check the hydraulic fluids, they'll check the tires, they'll check the tire pressures, and they'll check for damage as well. So it's a very thorough and comprehensive check. Just whilst I'm going on, I can't actually see the chat view on this. Just seeing if there are any. Can't see any chats, but if there are any questions, feel free to post, and maybe one of the moderators can forward those to us. So this is about 2 hours prior to departure that the maintenance team will thoroughly inspect the aircraft and get it ready for the flight. Moving on a little bit closer prior to departure, about an hour and a half before departure, the crew will start to arrive at the airport. So that's both the cabin crew and the pilots. And we meet together in the same room. There are 4 cabin crew on the 737, but that could go up to 10, 11 cabin crew on the 787. Now, typical things during the briefing are going to be, for the cabin crew, a safety briefing. So they refresh themselves of safety procedures. We've got very comprehensive operations manuals, and the cabin manager, who is the person who is in charge, will actually ask questions to everyone else to check that their understanding and their knowledge is up to scratch. So every day people are tested on their knowledge. Then they'll pick a topic that they can talk about. That could be anything from the slide rafts to the seat belts to looking after people with reduced mobility. And they'll have quite a thorough discussion about that. They'll also be given a lot of information about the passengers as well. So you may have heard of a passenger manifest. So that's a list of everybody's names who are going to be on board that flight. That's going to also include their seating position, who they are with their booking reference numbers. And all that information can then help the cabin crew resolve problems. So for example, if during check-in that family were perhaps split up, then they're all going to have the same booking reference number. And it could be that the cabin crew can then sort that out once they get on board the aircraft to try and relocate the passengers to who they wish to be seated. A lot of that depends on how full the flight is. If it is full, sometimes you perhaps need to ask other passengers if they'd be perhaps willing to move or not. But that information is given to the cabin crew. They're also given information on dietary requirements or allergy requirements. So sometimes we could be having someone on board the aircraft who's got a nut allergy, and therefore there's appropriate steps and procedures that we will try and eliminate the risk of any nuts, prevent that passenger from having a reaction. As I say, there's dietary requirements on there. So the typical ones are vegetarian, vegan, dairy-free, gluten-free, that kind of thing. So any meals that are prepared, they will have been pre-ordered. And again, the cabin crew will have those meals in the oven, but then they might not know who they are, but the manifest details who they are, where they're sat, so the cabin crew can quite professionally go straight to that individual and offer them their dietary requirements. The pilots will also come in at a similar time, and then we start our briefing. Just found the questions over here. Here we go. Excellent. So, right, so pilots briefing. So we've all got iPads that we use now. We've had laptops previously. We've moved over to iPads more recently. And they are our workhorse. We have all our operation manuals on there. We have all our maps and charts on there. We have calculators that work out our takeoff performance and our weight and balance. And we can also download all the flight plans from the operations department. So one single click and that information is all downloaded into one application. And that's very well presented. And we can actually then activate that flight and we run it in real time and log information as we go. I'll talk a little bit about that later. So during the briefing, when we first arrive at the crew room, we'll introduce ourselves to the other pilot and also the cabin crew, and we'll have a quick chat, usually quite informal to start with, just to build a little bit of rapport. And then we'll have a look at these briefing packages that our operations department have prepared for us. So we'll be going over that information and we'll be checking that us as pilots, we think that that is a good idea. And that's where we rely on experience a lot. We look at the charts for the wind and maybe thunderstorm activity. And occasionally, flight plans do have us perhaps going through quite an intense thunderstorm area. And that will be at that point that we can then pick up the telephone and we speak to the dispatcher, that is somebody who works in the operations center, and we can discuss our concerns perhaps or our ideas, and they can either confirm what they've produced already, or they can say, actually, yeah, we've perhaps not thought of that idea, or the computer's missed that. In which case you can then come up with a second plan and then organize that, and then those new flight plans will be filed. So what is presented to us as pilots when we first come to work is not always necessarily set in stone. We can make that decision that we might want to change some of it, or we may decide that we require more fuel than they're suggesting. It's not very often that we would suggest taking less fuel. That's very rare. In fact, in my entire career, I don't think I've ever taken less fuel than what the operations department have said. So there are minimum requirements that we have to meet. We'll consider the weather at our departure airport. We'll consider the weather en route, and we'll also consider the weather at our arrival airport. One thing to consider is certainly if there are thunderstorms forecast or strong winds or heavy rain or snow, then we'll certainly have at least one alternate airfield that we could go to. But if the weather's quite bad, we'll certainly select 2 different alternate airports. They're usually quite nearby, and that gives us options that if there is a snow shower over one of the airports at the time that we get there, we've generally got options that we can get the weather for the other airfields that are nearby, and we can then go there should we need to. Once we've considered the flight plans, considered all the information available to us, we'll then pass some information on to our handling agent, who looks after the passenger side of things and the actual getting that aeroplane to move. So we buy that in. It's not run by our company, it's a different company. So we'll phone them up, and we will give them how much fuel we would like putting on the aircraft. We tell them how much fuel we're going to burn that day. We'll tell them the flight time. We'll tell them how many crew are on board, and we'll also give them what's called a catering code. So that's all the meals, the duty free, and all the drinks that we carry. We've got specific weights for different destinations. So we'll give all that information to the handling agent so that they can go away and they can compile what's called a load sheet, and they know exactly how heavy that aeroplane is going to be. So I'll come on to that a little bit later. Just before I move on, I'll quickly just take a couple of these questions. So the first one there is, how long does it take to train to become a pilot? There are a couple of ways of doing it, but the way I did it, and the most popular way, is to go on a dedicated training course. That's called an integrated training course, and that takes around 15 months to go from 0 to about 200 flying hours, and you will get a license at the end of that, and that will be called a frozen ATPL. We like abbreviations in aviation, and ATPL stands for Airline Transport Pilot's License. And the frozen bit of that means you're limited to what you can actually do. So you can't be a captain with a frozen ATPL, and you will generally be, the rank will be a second officer. Once you've done 1,500 hours, you can then unfreeze that, and that becomes then just an ATPL. And you generally get promoted to the rank of first officer. So the license takes about 15 months to get. You then need to do a type rating. Now, what's involved with the type rating? If we take driving licenses, for instance, so you learn how to drive a car, you then take your test, you pass your test. The very next day, you could jump into a Ferrari, you could jump into a Volkswagen Polo, you could jump into a Bugatti Veyron. Absolutely no problem. And you can drive those cars perfectly legally. Flying is a little bit more different, because we've got different aeroplanes work differently. So you may have heard of Airbus, and you may have heard of Boeing. Now, Boeing, American, they have been going a very, very long time, and they've got their way of making aeroplanes and how they make the hydraulic system, the flight dynamic systems, the computer systems. and they're very good at it. You've also got then Airbus, which is European, started off in France, but it's very European company, and they've got a different philosophy of how they think an aeroplane should fly. So the difference between a Boeing and an Airbus is massive. It is a completely different philosophy. So you can't just jump into these aeroplanes and start them up and away you go. But the same within Boeing. So if you take the 737, that's very different to the 757 and 767, which is also very different to the 787. So you then learn that particular Boeing aircraft. I did mention right at the start that the 757 and the 767 were very similar. And in fact, actually, you could fly both of those aircraft types together, but that's quite unusual. So they did that intentionally, but it's not really followed through. Airbus, on the other hand, they've got the A317, A318, A319, A320, A321, A330, A340, A350, A380. And actually, they all use a very similar philosophy. And therefore, their type ratings, they are a lot more fluid. So you can actually move around those aeroplanes a lot easier. So with this type rating, how long does that take? It usually takes around 6 to 8 weeks of ground school and simulator training. And then you're probably looking at another 4 to 6 weeks of actually flying the aeroplane. So you will first of all go with a training captain, and they will guide you through, give you the right techniques. So in total, you could be looking at anywhere between 10 and 16 weeks to do a type rating. So what's that, 2 or 3 months on average to do a type rating, maybe a little bit longer. So all in all, from 0 to being able to fly a 737 is going to take about 2 years. That's the first question. And could you please share your first takeoff experience? Yes. My very first takeoff in a light aircraft, so it was a little Cessna 152. I can remember it well. All those years ago, back in 1996 is when I first started to fly. And yeah, just that experience of the lift off and getting airborne is an incredible feeling. When you move on to a jet, so I went from a 5-seater twin propeller aeroplane, I went straight up onto the 757, which is a very big jet airliner. And the amount of thrust, it throws you back into the seat and you launch off at quite incredible speeds. We take off at around about 160, 170 miles an hour. And the climb rate is very impressive as well. So the sensation of taking off is quite unique, really. Us as humans, we don't fly. You know, this is an artificial thing, but it's a wonderful experience. So that's covered all the questions so far. Feel free, yes. And I'll kind of
sorry to interrupt, Simon. There's one other thing which has come in the chat. Actually, they were asking. I'm sure you said about the route to get trained. Is there a particular characteristic or personality who will be well suited to become a pilot? There's a question in the chat forum.
So best personality.
Yeah. Anything in particular that you would say?
Yeah. So We want people who can communicate. That's that they can talk, they can share ideas, they can listen, and that they can also think for themselves. One thing that hopefully you'll see from the presentation, and you've probably started to get a taster, there's no single person can fly an airliner. It takes a massive team to get 200 tons of aircraft into the sky every morning, and you need to be a team player. So the type of personality is someone who's open, someone who's honest. They can listen to training input, because it's like any skill. Nobody can do something perfect first time, every time. You know, flying is a skill that we have to learn. And whether you're a dentist, a doctor, or someone who works in architecture, you know, they're all skills that we learn as a trade. So flying's no different to that. But one thing we have definitely learnt over the years of aviation, and we're an industry that we really analyse accidents and why things go wrong. And fortunately, you know, it's a very rare event that we have an accident. However, when there have been accidents, there is a lot of time, money, and investment spent to analyse what caused that. And sometimes it can be mechanical failure, but over the course of history of flying, there's been quite a few issues with the crew. Either there was an incident many years ago. It was winter 1989, the Kegworth incident. It was a 737. It was a brand new aircraft. It took off out of Heathrow, and unfortunately it lost some oil out of one of the engines. The oil cap hadn't been put on correctly with maintenance, so there was a maintenance issue there. That engine then lost the oil, and it was in the process of making an emergency landing into East Midlands, and it had very severe engine damage, and the cabin crew insisted that it was on the left-hand side of the aircraft that the problem was. Oh, was it the left? Anyway, but the pilots, all their indications were showing it was on the right-hand side of the aircraft. What transpired from that investigation was the pilots look forward, their left-hand side is the left-hand side looking forwards. The cabin crew were trained to actually face the passengers and look the other way. And their left-hand side was actually the wrong side. Their left-hand side was actually the right-hand side of the aircraft. And that was a major eye-opener for the industry, saying, well, hold on, the cabin crew could see which engine, it was on fire. You know, there was flames and sparks coming out of it. They knew exactly which one it was. However, when they presented that information to the flight crew, that conflicted with the information that the flight crew was seeing on their instruments. And that caused them to effectively shut down the wrong engine, because the left and rights got confused. It seems very simple these days, but sometimes it can be quite simple events that do actually cause incidents and accidents. But as an industry, we went into that, we analysed it, and developed a method to keep it all standard. So the cabin crew now refer to the aircraft as the left and right, the same as the pilots do. And that's how you learn from that. So going back to that original question is being able to listen, train, be open and honest, and offer feedback as well. So it's a whole mixed bag to make an individual character someone suitable for an airline pilot. And you need to be passionate about aviation as well. But most people who come into aviation, they get that bug, and that's it. They rarely move on. So hopefully that explains.
I've got a cheeky question coming up, Simon. Somebody's asked, a good friend of mine has asked, how are pilots always fit and trim?
How are pilots always fit and trim? In regards to health, we get all kinds of characters. So I have to say we've been severely affected by the COVID-19 pandemic. So I've actually lost a lot of weight during the pandemic because I eat healthier. I've had a good lifestyle of going to bed at regular times, getting up at regular times, and not eating crew food. That's probably why I'm fit and healthy. However, I'm back to working hard again. This morning I was up at 3:30. This morning I went to Mallorca, and actually after this webinar I'll be going back to bed because I'm up again at 3:30 tomorrow morning. So they are not healthy lifestyle choices, really. Unfortunately, we are a 24-hour operation. Sometimes that means waking up very early in the morning. It means sometimes going to bed very late, or very early the following morning. Yeah, so it's sometimes very difficult to be fit and healthy and look after ourselves. So it is an important factor that I think during this lockdown that we've just experienced, so many of us have actually realized we actually need to be better. We need to look after ourselves better, and that's good hygiene. And I don't necessarily mean sort of showering and deodorant hygiene, but sleep hygiene. Make sure we do get good sleep. I was watching this presentation a little bit earlier regarding the devices and bedtime sleep. And yeah, we as an industry, we wholeheartedly support that. You know, sleep hygiene is very, very important for us as humans. But when you do shift work, and I'm sure many of you are listening do shift work as well, it is equally as important. Another question there, what's the difference between a fighter and commercial pilot? They're actually becoming more and more similar. Fighter pilots are generally selected for not being team players, would you believe? They are after people who can think independently. They can make accurate decision-making processes 100% of the time on their own without anybody else, because generally they don't have anybody else. They're on their own. There's a lot more technology going into fighter jets now. Sometimes you do have maybe a navigator at the back or a weapon system operator, but they are single pilot operations. Whereas an airline pilot, kind of what I just mentioned a few minutes ago, we're a team organization. We don't actually want people who are single pilot operators. We want people who can work as a team, because it's that team that's going to actually be more successful than that one individual person. So it works well in warfare, but in commercial operations, not so much. So that's the difference between those. Right, so the questions over there. Right, so the crew briefing, I think we've kind of covered all of that. That's about an hour and a half to an hour before takeoff time. What is happening about 50 minutes before departure, around the aircraft will start to come alive. They may have been shut up all night, no real interaction. The engineers may have had a look around that aircraft, but otherwise there wouldn't have been a lot going on. But about 50 minutes prior to departure, everything starts to happen. So we'll have phoned through to our handling agent and given them a fuel figure. So that's how much fuel we want. And that fuel will start to be loaded on. What you might be able to see from this slide in particular is the left-hand side as we're looking at it, but the right-hand side of the aircraft is where the fuel truck is. There's a catering truck there. Right at the front under the nose, that's a ground power unit, so that's providing electricity to the aircraft. Generally, all the services are on the right-hand side of the aircraft. And then on the left-hand side of the aircraft, there are steps, and that's going to be for the passengers. There are some aircraft types where they have fueling on the left-hand side of the aircraft, but they are few and far between. Most aircraft are fueled up on the right-hand side. So busy time. As I said, the fuel's going to be going on. We actually plug in drinking water, and fresh drinking water is pumped on board the aircraft into a sealed tank. The aircraft will be cleaned. It's usually cleaned prior when it comes in from the previous flight, but the cleaners will probably have a quick go over it. All the bags will be loaded on, and also the catering will be loaded on. So that's about 50 minutes before departure. And as I say, if you're at the airport looking at an aeroplane and you start to see quite a bit of activity going around it, that's going to be going within the hour. I just mentioned it earlier, passenger boarding. So traditionally as well, the passengers get on the left-hand side of the aircraft, and that keeps them away from all that servicing side of things. So the fueling, in fact, you can even see it in that picture just under the wing. There's two gentlemen in a high visibility jackets. Just behind them, there's the fueler there, and they're putting the fuel on whilst the passengers are boarding. What else is there about boarding? So this aircraft on the slide has got integrated steps. That's quite a rare thing. Ryanair have got it. It speeds up the process that they don't have to wait for steps to be brought to the aircraft. But normally there's steps on wheels which are pushed to the aircraft. And other options are air bridges. Usually only one air bridge is attached to the aircraft, and that's a connector that connects the terminal to the aircraft. So if it's raining, you don't get wet. Some of the bigger aircraft, the Airbus A380, the great big massive double-decker aeroplane, some airports have got facilities to connect two air bridges to that, and that'll speed up the boarding process. Quick questions popped up. Do pilots use sleep aids like melatonin? We're not allowed to self-administer drugs, full stop, is the legal answer. Maybe if you've got a headache, you should be okay having the odd paracetamol here and there. But no, we're not allowed to take any forms of medication without consultation with medical advisors. Every year, I'll just quickly talk about that since it's come up. Every year we have a medical examination for anyone under the age of, I think it's 60. Once you get over 60, you go for a medical every 6 months. But I go every year, and it's a full medical examination. So that includes eye testing, ear testing, checking inside the mouth. We'll be checking my heart, so that's done at every time as well now. So I get plugged into an ECG, with an electrocardiogram, so that takes a sample of my heart, and if there's any things that could crop up before they actually become a problem. There's we take a urine sample, and that's to check for things like sugar in the urine. A blood sample is taken as well, and yeah, we get a thorough medical examination. So if we feel that we need a medication, or we maybe have some surgery done, anything like that has to go through our medical examiner, and we have to notify them. And it could well be that we are taken off duty for a period of time. So for example, if you have a medical procedure with a general anesthetic, you could be off work for certainly a week, maybe a bit longer, but there's a lengthy process to then getting your medical back. So self-administering drugs is not an option for pilots or cabin crew. So there are very strict rules on that. Basically, we're not doctors, so you know, you wouldn't want to be taking something you shouldn't be doing that could affect your vision, ability, decision-making process, things like that. So as I say, it is highly regulated. What we've got, 15 minutes, good stuff. Right, flight deck preparation. So the passengers are boarding, you've got 2 crew there, generally we're 2 crew these days, and we're going to go through setting the aeroplane up, that's turning everything on, programming the navigational computers. So it's basically your sat nav, your TomTom that's going to take you there. You can see there's lots of buttons on there, lots of switches. Generally down the bottom is radio panels. Behind the guy's iPad is the thrust levers. And then we've got the display screens in front of that. And that means that we can fly in cloud and not have to look through the windscreen. And then we've got the overhead panel, which is generally a lot of the systems. So we've got fuel systems, hydraulic systems, air systems, engine start systems. So lots of switches and dials and knobs up there as well to set the aeroplane up ready for departure. We'll then also do a briefing. So the pilot flying, and that could be either the co-pilot, that could be the first officer, or the captain. Generally, we decide one of us is going to do the flying. The other person is going to do the radio and also all the paperwork. So that's the logging of the flight. So we've got a record of what happens. And that person is also going to monitor the pilot flying as well. So at all times, effectively, both pilots are flying the aeroplane. One's physically doing it. The other one will be mentally flying that aeroplane. And that's to make sure that you're doing the right thing. And if there's something not quite right, then we ask questions. Is this right? Why are you doing that? Should we be doing this? those kind of open questions. So we're going to go through a briefing and we're going to explain how we're going to taxi the aeroplane out to the runway, how we're going to take off, and then how we're going to fly that aeroplane. We also do a lot of threat identification and mitigation as well. So if we know what threats we may come across, then that's half the battle. If you've then got an idea of how you're going to deal with that threat, should it happen, that's nearly 90% of that battle completed, because you've identified what may occur, you've come up with a plan on how you're going to deal with it. So if something goes wrong during either the takeoff run or shortly after you get airborne, you have that plan in your mind of exactly what you're going to do, and you can go straight into it. And the other person is going to know exactly what you're going to do, because it's quite time critical during those phases of flight. So that's the briefing. And then after that, once everybody's on board, we've got some paperwork that we hand off. So we've got some takeoff calculations that we've worked out. We've got some load sheets that have come on board, telling us exactly where everyone's sat and where the bags are, and we know exactly how much that aircraft weighs. So that's going to be taken off board. So there's a copy of that kept on the ground. There's a copy of the technical log. That's a document that we keep on board the aircraft, and where we record all the fuel that we put on board the aircraft, all the fuel that we've burnt off the aircraft. We keep a record of engine oils on there as well, and also any defects. So if there's any problems with some systems that aren't working correctly, then there's a record of that as well. And again, that is taken out of the book and kept on the ground as well. So once all that's happened, the doors are closed, we connect a tug to the aircraft, and the aircraft then gets pushed back. From there, you'll start to hear the air conditioning will go quiet, because we use that air conditioning air to actually start the engines. So we blow high pressure air through the compressor. It was part of the engine. It's kind of in the middle of the engine, and we literally blow it round and round at high speed, and then we'll put some fuel in. Then we'll turn the igniters on, and it creates the engine running. And once either 2 or 3 or 4 engines are all running, the tug will disconnect, and the ground crew will walk away from the aircraft, and you'll be left on your own. And that's your time then to get permission from air traffic control, and you'll taxi the aircraft out to the runway. As passengers, you'll notice that the cabin crew do a safety briefing. That could be a video, or it could be done over the PA. And then they'll come through the cabin and make sure everyone is strapped in. As I said earlier, we're hurtling down the runway at 170 miles an hour before we take off. It's very important that those seatbelts are fastened. Once they've been through the cabin and checked that everyone is safe and secure, they'll then telephone the pilots, and they will inform us that everything is safe and secure. We will not take off until we've passed that bit of information. And then the final bit is we get airborne. So we'll advance the thrust levers, set takeoff thrust, and away we go. Just one little thing regarding takeoff thrust. It's very rare we use full power. We actually use a complex computer program to work out how much thrust we're actually going to use to take off. So we know how long the runway is. We're going to maximize how much of that runway we're going to use. We're going to use as little power as possible, plus a safety margin. So we always have a safety margin built on top of that. But the idea of taking off with reduced thrust is it saves fuel, it reduces engine wear, it makes less noise, and it's better for the environment. So yeah, it's good that we take off with reduced thrust. So it's very rare that you'll be on an aeroplane that is taking off on full power. The only times we tend to use full power are quite short runways where it's particularly hot. So, for example, maybe Zakynthos, a smallish Greek island, their runway is not the longest. It's perfectly adequate, but it's not the longest. And if it's 35, 36 degrees Celsius outside, then we'll probably be using nearly full power. So, but it's quite rare that we use full power. We use really just enough to get airborne, plus a safety margin, and that's about it really. I've got about 6 more minutes to go. We kind of left this.
Question, Simon.
Oh yeah, go on, Dinesh.
Yeah. You were saying, what is this black box about?
Black box. There's actually no such thing as a black box. They're usually bright orange boxes, but it is called the black box. It's a magical box of tricks. There's usually 2 on board. There is one which is a flight data computer, and the other one is a voice recorder. So first of all, the voice recorder, that is activated from, there's a little switch actually on the 737. You turn it on and it starts recording right from the preparation of the aircraft. Or the more later aircraft, as soon as power is applied to that aeroplane, that will start recording the voice. Traditionally, they were on tape and they used to record about 30 minutes and it would be a continuous loop. And there's a little microphone in the flight deck, and that is recording the conversation between the 2 pilots. Because if there was an incident or an accident, then the actual conversation between the pilots can shed so much light on what has happened, rather than investigators trying to work out just from the data side of things. So the voice recorder is very important. It can also record little clicks, little sounds, little switches. And again, a lot of the switches and levers within a flight deck have their own little signature sound. So if you replay that sound, you can actually tell what switch was perhaps being pressed or turned. So that's the voice recorder. The more modern ones, and I think just about on all aircraft now, they're all digital, so they're recorded onto microchip, and I think they can record anywhere over 8 hours worth of recording. So you can recall a lot of data. With the flight data recorder, that is recording pretty much every single parameter within the aircraft, and that's whether it's the control column that we use to fly. It can measure how much input we're putting in. It records every single data input from every single sensor on board the aircraft in real time. So should the investigators wish to replay an incident, they can download all of that information and plug it into a computer, and they've got lots of screens and they can see exactly what was happening on that flight at that time. Now, the reason why they're in great big orange boxes is really so upsettingly really is that they can be found easily. If there was a unfortunate catastrophic incident, they are made out of exceptionally tough material with heat-proof insulation as well, and they can withstand the most severe impacts. They can withstand being under the sea for months on end. They have their own transmitters on board, GPS locators, and they will be sending out radio signals pinging to be found. So, but they're in bright orange boxes to make them highly visible. So that's your black box, and there's 2 of them.
Thank you, Simon. I mean, going back to what you mentioned earlier about airline safety, I mean, it has even come from you guys to medical specialties as well. At least the intensivists and the anesthetists who are listening, they'll know how much we have learned from you guys. And I'm sure it'll be helping other industries as well, safety-wise. Yeah, you guys are leading the way.
Yeah, thank you very much for that. Certainly, I believe we've, for a very, very long time, years and decades even, we have quick reference handbooks. We can't possibly know everything about every system on board the aircraft, inside out, in an emergency situation, split-second decisions. So we decided it was perfectly acceptable to have, and we call it a QRH, it's a quick reference handbook. So if we get a light come on, we can quickly refer to that light, and that will go through and then give us a list of procedures to follow to either rectify that problem or isolate that problem to stop something else from happening again. And that philosophy has certainly gone into the medical industry, but there's also a number of industries that's gone into. People always thought everyone should know everything by memory. There are certain things which we do memorize. For example, engine failure after takeoff, they are memory items. However, the majority of things are actually in a book so that we actually get it right and we don't make mistakes. And that is acceptable. Whereas in the past, perhaps different cultures, different even age groups would think, oh, well, we should know everything. Well, no, we can't possibly know everything. But what we do want to do is get it right. And that's where these quick reference handbooks help us get it right. So, yeah, that's good stuff.
Thanks. Thank you, Simon. That was quite an interesting talk.
Well,
thank you,
hopefully, yeah, thank you very much for having me. That's 8 o'clock, so I'll let Dinesh sign off. But thank you very much for having me. Hope you found that interesting. A different little perspective on how to get an aircraft airborne in the morning. So thank you very much. Good luck with the rest of the evening, and I'd like to wish you all the very best. So thank you for having me.
Thank you, Simon. It was certainly interesting. Thank you.
Thank you, Dinesh. Thank you, Simon. Thank you.
Thank you. I would just request everyone who has enjoyed, continue enjoying the program and donate as much as you can for a noble cause. Thank you, guys.
Sorry, thank you.
You cannot share Kavi, enna co-host podano.
I think we're just getting ready for the next presentation. We have got the next moderators and presenters here. I'll just wait for them to take over. Hi, Ravi. Hi, Sridhar. Hi. I'll sign off. You guys take over. Thank you.
Right. Dinesh, you guys can hear me?
We can. I can.
Hi. Hello. And we okay to start now?
Should be good, Ravi. Thank you. Yeah.
Hello, everyone, and the RISE Foundation is doing extremely great job by bringing this wealth of knowledge, information to make the life better. Um, I don't have enough words to praise this group, and I'm happy to be part of it. Uh, Next 1.5 hour, we have a very useful session coming up. With the current lifestyle changes and the way human life has gone, the problems related to the muscle, joints, and limbs have taken significant chunk of medical problems, and we have uh, three absolutely brilliant authorities here who are going to guide us, who are going to help us and answer the questions. Together, they have wealth of knowledge. I can see when I went to the CVs of three speakers, I am absolutely humbled. We have nearly 80-90 years of experience with of us, and I really want all the audience to gain from this experience. um, my very close friend Sridhar Arani, he is going to talk on pediatric rheumatological problems. This great singer has more than 30 years of pediatric experience, including in India, in NHS. He has been working in Leicester Royal Infirmary, and he is also honorary senior clinical lecturer in University of Leicester. He specializes in pediatric rheumatology, and he's gonna talk on acute and chronic problems of joints in children. Next on the list is my close friend James Francis. He has more than 15 to 20 years of experience in rheumatology. He is very eminent rheumatology expert in Leicester. He has led the rheumatology services in UHL, which caters more than million population here. He has been training program director also for rheumatology. That's a very prominent and a very responsible post in the world of rheumatology in our East Midlands. And his expertise are in osteoporosis, metabolic bone disease, and I am really eager to hear from him. The lighthouse for all of us and the pinnacle of the profession in Leicester for us is Professor Murthy, and I am really humbled to meet him and introduce to him. I'm really a small person to introduce to him, but I'm going to put some words. Professor Murthy has years of experience in rheumatology, including India, UK, and overseas as well. He is an honorary associate professor in University of Leicester. He is visiting international professor in India and Georgia. He is always on great panels for national, international meetings to give his talk, and people learn from his experience. And we all are. Really eager to learn from him, his experience not only in rheumatology but in life and how to progress. And I hereby present the panel to you. The plan is the speakers will speak for 20 minutes each. Then I will take the questions by the end of all the talks so that all the authors can give their views on particular problem. So over to you, Shri.
Thanks, Avi. That's very kind of you. I'm really humbled by your introduction. And thank you, Rise, for a fantastic webinar, for an excellent cause. It's my absolute pleasure to join this session. Thanks for having me. And good evening, ladies and gentlemen, my dear friends, and also all the lovely children who have been a part of this journey. I hope all of you had a lovely time so far, almost 8.5 hours with excellent presentations from both the UK as well as the speakers, international speakers. And I would like to share the screen actually, so if that's okay. So today my talk will be particularly focused on musculoskeletal problems in children, both acute as well as chronic. And I would like to address this topic particularly to the public families and friends with the children who may have children with joint symptoms. And as the words say, pictures speak 1,000 words. I would like to show you a number of pictures that will be self-explanatory. And due to time constraints, I would try to won't go into too many details. You can always put up the questions in the Q&A chat box, and Ravi will pick it up at the end of the session. Yeah. So with that intro, I would like to start off with My objectives is I'll try to address a number of clinical presentations, acute ones which needs an urgent review, and obviously I tend to get involved more with patients or children, say chronic joint pains, children with childhood arthritis, what we say is juvenile idiopathic arthritis, children with hypermobility of joints, and also try to give sort of a flavor of what is the general approach to the treatment and management. Yeah? Now, fractures are quite common in children. And in fact, as a child, I did have a beautiful nose and had a fracture doing some circus with parallel bars. And so I got a broad nose, which I like. So this is quite a common presentation where Ravi gets more involved. This is a typical fracture of the radial bone, what we say is the buccal fracture. And then this is a patient with elbow fracture. And there's another one with a buccal fracture, and there's a patient with femoral fracture. So this is quite commonly we tend to see in children who are quite active and playful. So there's nothing major to worry. Usually they tend to recover within a few months. But the small group of children where the patients tend to have multiple fractures, they need a little bit more investigations to look at whether they've got a fragile bones or whether they've got a vitamin D deficiency. Obviously, that'll be investigated. Now, this is an interesting group of children, especially the infants less than 18 months, 2 years. If you have a fracture, particularly the spiral fractures, that's a cause for concerns. Remember the word, children who are not cruising or non-mobile, they're unlikely to bruise or fracture. So this always raises a concern as to whether there's any safeguarding concerns. So pediatricians, we get involved in looking at the safeguarding concerns, and I've been the safeguarding lead for one of the largest trusts in the country for almost 10 years. And I had to produce many medical reports along with my colleagues, and also I've been to the court a number of occasions actually presenting evidence. So this is an interesting entity. So health professionals who are involved with dealing with fractures, they know the safeguarding systems very well. Now, this is another common presentation. We tend to commonly see children presenting with acute onset of limp, and when you examine them, they look reasonably well. They're not febrile at all, no history of any injuries. They had a cold a week ago. And when you examine them, the limping, the restricted hip movements, and when you do the x-rays and read, so like the x-ray on the right-hand side, everything seems to be normal. And if you're lucky enough to get an ultrasound or MRI done, you might pick up a little bit of fluid, what we say is the transsinovitis. And all these patients, they recover completely with the help of a little bit of physio and pain relief. So the important thing is that they need to be reviewed by the GPs or some sort of a setup to make sure that they're completely recovered and we're not missing out anything else. Now, this is obviously a serious entirety. We do tend to see a small group of patients with septic arthritis, or what we say as an infection of the bone called osteomyelitis. These children are quite acutely unwell. They have a high temperature, and with the next slide, I'll show you that they've got a significant joint swelling, red and hot, and these patients need urgent intervention. This is where the orthopedic surgeons get involved. They need imaging, blood tests, and also joint washouts and antibiotics. The pediatricians get involved and ensure that they get appropriate duration of antibiotics, and also we're not dealing with any immunodeficiency. So the one on your left, you can see this is a slightly older patients with a grossly swollen red knee, and you can see probably the entry of infection could be an injury here. And this is a classical case of septic arthritis. And the one on the right, the upper part of the bone is a normal one, and this is a mucky looking one, and this is where I think that this patient has got osteomyelitis. Again, these patients need intervention with the prolonged course of antibiotics up to 4 to 6 weeks. Yeah. Now, most of the times the x-rays are reasonably normal unless until you've got a trauma. Sometimes the x-rays are very, very helpful. So if you look at these few x-rays, the right side of the anatomy looks entirely normal. The left side, this patient present with the left hip pain, this looks, the anatomy looks a little bit distorted, and similarly this one as well. And this is an MRI picture, slightly masked, apologies for that. And this is the classical case of children with the Perthes disease, what we do the orthopedic surgeons, and they deal with them. And it's a combination of physio, pain relief, and a follow-up, and sometimes surgical intervention in some cases. Now, again, this is another case where the x-rays are very useful. This is an x-ray of 15-year-old adolescent, a slightly obese child presenting with acute onset of limp on the left side following a minor fall. You think that is a fracture, but this is not a fracture. If you look at the right side, it's entirely normal. But on the left side, you can see that this is slipping off what we say is the capital femoral epiphysis. And again, this the right side picture also shows the same thing. Now, this is a classical case of what we say is the slipped capital femoral epiphysis, and this needs an urgent intervention by the orthopedic surgeons, and sometimes the delay in cause long-term hip damage. And of course, we do tend to see a small group of children who are slightly unwell. They present with ongoing aches and pains, generally unwell, and they tend to have bone pains, nighttime pains, night sweats, the losing weight, and the lack of appetite and everything. So this is where we're looking at whether they got some sort of hematological malignancy, like leukemia, lymphoma. They may have lymph nodes, they may have enlarged liver and spleen. And obviously, a persistent severe bone pain. When you do X-rays, you can pick up the bone cancers in children as well. And sometimes we can pick up what is known as osteoid osteoma, which is a benign tumor of particularly the long bones, which present to the persistent unilateral, what we say is one-sided pain. And these are easily picked up with the investigations and can be treated. Now, the picture on your left side is a classical case of a child with a Bolex, and this is due to a severe vitamin D deficiency. Health professionals have been trained in it. This is a very familiar picture. We used to see plenty of patients with multiple bone deformities to rickets. Fortunately, we don't see it in UK, and I've hardly seen 3 or 4 cases in the last 25 years I've been in UK doing pediatrics. The one on the right side is a patient with scurvy or vitamin C deficiency, and this is the classical picture of the X-ray. Now, this one, they may not have a joint swelling, but it is acutely painful, and they may not want to use their limb, what we say is pseudoparalysis. Again, fortunately, we don't tend to see these presentations nowadays. Now, that's the spectrum of the acute joint pains. And now the chronic joint pains, again, there's been a significant increase in the number of patients present with chronic joint pains. Previously, about 10, 15 years ago, we used to do only 2 clinics per month. And now I do about 8 to 10 rheumatology clinics. In spite of that, there's a significant number of referrals and significant weight. And this is the spectrum of patients we see: the chronic knee pains, the chronic low back pain, the generalized chronic joint pains, and also we do tend to see a significant number of patients with childhood arthritis, what we say is a juvenile idiopathic arthritis, and then there's a number of referrals for dealing with patients with hypermobility joints. So chronic knee pain is quite a common presentation in children less than 18 years. Usually it tends to affect the front and side of the knee. They don't have any swelling. It tends to be much worse during the growth spurt, particularly in children who are doing a lot of sporting activities and running. And on close examination with the physio, sometimes you can pick up they have weakness of the quadriceps muscle and also the gluteal muscles. And this one condition, what we say is Osgood-Schlatter's disease, where there's inflammation of this point, where there's insertion of the patellar tendon into this thing, where you have a little bit of a swelling, redness, very painful, particularly common among sporty children. And usually it tends to resolve with a little bit of physio, painkillers, and a rest. Back pain, again, is quite common. Almost 10 to 20% of children do present with a low back pain, predominantly because of what we say is the biomechanical reasons, number of reasons: poor posture, lack of activity, lack of core strength, and also carrying heavy school bags, etc. Now, the question is that when do you worry? Now, if the child is less than 4 or 5, or it's been going on for quite some time, and it prevents the child from doing their activities, if this is associated with a fever, weight loss, and if you've got a pins and needles, numbness and mucus, all this indicates there's something going on. Or if you develop an altered curvature of the spine because of the backache, and it's associated with some weakness of the legs, and if you've got a bladder bowel distances, that is really, really worrying. And that needs to be seen by the medics and investigated appropriately to arrive at the exact reason for the back pain. Now, this is a very common entity, and most of you with the children going through the paces, many children, they do have present with growing pains, particularly common in children less than 12. They're quite harmless, and but they can be very painful. And these children are typically very well during the daytime, and they tend to complain of more during the evenings, and this can last up to months and sometimes even years as well. The important thing is that it doesn't affect the joints. It tends to affect predominantly the muscles like the thighs and the calves. And then the daytime, they seem to relate really very well. And in my particular experience, I tend to see more of these patients, especially if they're very, very flexible. Now, how do you manage growing pains? It's always a common question. I don't tend to see many patients again because the GPs tend to manage them, and I tend to see the tip of the iceberg. Important thing is having a routine, having a warm bath before the bedtime, and gentle massaging of the legs, and using the simple heat packs or warm water bottle. And also sometimes occasionally they may need a little bit of paracetamol and ibuprofen. And many of the children can have slightly flat-footed, which is naturally be there in younger children. If they can wear supportive shoes such as trainers and everything during the normal day-to-day activity, they tend to be very helpful. Now, when do you worry? With the growing pains, sometimes it's always worrying for the families as to when do I need to go and see the GP or seek medical help. If the pain is affecting only one leg, and if pain carries on the next day, it's affecting the routine of the child, affecting the PE activities, and if it's associated with any swelling or a rash or a bruising or a high temperature and losing weight, all this indicates that something else is going on. That needs medical intervention. They need definitely seek help through a GP or the emergency department or the pediatrician. Now, childhood arthritis is something general public won't believe in, and they think that always arthritis is a common problem in adults, but it's very well known for hundreds of years that arthritis can affect children. What we say is inflammatory arthritis, and we call this as juvenile idiopathic arthritis. Now, it's a group of conditions in which the chronic arthritis lasts more than 6 weeks, presenting before the age of 16. Now, these are the criteria. The age is less than 16. That's the reason we call this as juvenile. And arthritis, you should have a clinical evidence of a swelling of the joints affecting one or more joints, or some sort of a radiological evidence in the form of ultrasound or MRI. And the duration should be more than 6 weeks. And the last important criteria is that we should have ruled out the other condition which can present with hip pain and all those things I've spoken earlier on before we say this is juvenile arthritis. The reason being it's a lifelong diagnosis, so I tend to see them only after 6 weeks. So it affects all the races and throughout the world, and the incidence in UK is about 1 in 1,000. Females obviously predominate. And these are some of the pictures of my patients. You can see that this patient has got it's always easy to compare the joints to find out what's happening. So you can see that this patient has got a swollen right knee. And again, this patient has got a right knee, and this patient has got a left knee swelling. You can see, interestingly, this leg is slightly longer, and he walks with a flexed similarly, this other picture here shows a similar presentation. It can also affect the finger joints. You can see this child has got a swelling of the middle finger, and this child has got a swelling of the multiple finger joints in what we say is polyarticular arthritis. Now, these are some recent pictures from the COVID period where I had to do joint injections. This child showing a massive swelling of the right knee, and this one the left knee. And this child again has got a significant swelling of the testing. And these patients needed intervention in the form of medications, and also I do joint injections in these patients. Now, 1 in 4 children who got a diagnosis of arthritis can have eyes affected. They can have inflammation of the eyes, and if it's not picked up, they can lose their eyesight. So older children, sometimes they can present with a red eye, painful eye, or a bloodiness and floaters and everything, but younger children may not complain at all. So these kids, once you diagnose arthritis, they need to be seen by an eye specialist. So they get screened every 3 or 4 months to look for evidence of all these things on the left-hand side. If they've got inflammation, they're treated with steroid eye drops. If it's not picked up and treated effectively, and they can lose their eyesight. Now, I won't go into the details. The most important thing is that in arthritis, there's no cure. But we can, with the current modalities of treatment, we can treat them effectively so that they can have a normal life. And I think when the families and parents come to the clinic, it's always a shocker But when you reassure them, we can treat them effectively to lead a normal life. They're quite reassuring. And obviously, multiple professionals are involved in managing these patients, particularly the physios and occupational therapy team. Now, the medical management, again, I won't go into details. I'll touch upon what is the basics. We use anti-inflammatory medications, and the choice depends on the age group. And we also use the disease-modifying anti-rheumatic drugs. The methotrexate is something that has completely revolutionized the management and outcome in patients with arthritis, particularly in children. It does have side effects, but they tend to tolerate very well. And I do joint injections patients with this thing. And younger children, we need a general anesthetic to do joint injections, but older children we can easily manage with Entonox or laughing gas. And nowadays we tend to have a significant number of other therapies, what we say is a biological therapy, so with which they can have a normal lives. Now, it's a chronic disease which can't be cured, but it's treatable. And many times they're prone for remissions and relapses. At the age of 16 to 18, I tend to transfer them to the young adult rheumatology clinic run by one of my colleagues at the Royal. Now, there's a lot of patients where they present with generalized joint pains and bone swelling. When you examine them, they clinically look very well. There's no joint swelling. So this is not arthritis. And then we've got a significant number of patients who are very, very flexible. They have a lot of symptoms. This is what we call as the joint hypermobility syndromes. And then we've got a small group of patients who present with a lot of aches and pains. They look very well. When you do the vitamin D levels, almost 50 to 60% of patients can have vitamin D levels. If you treat them, usually symptomatically, they should get better. Now, this is a spectrum. These are beautiful children. You can see that they can do a lot of tricks. It's quite advantageous to be hypermobile, but many children can present with problems. Now, what is hypermobility? Now, the joints that are more flexible or move in excess of normal range is considered hypermobile. So when you've got generalized hypermobility of your joints with the symptoms, then you call this as a hypermobility syndrome. And really, we tend to sometimes pick up some genetic conditions like Marfan's and Ehlers-Danlos with this called additional morbidity. And the common terms used are double jointed, loose jointed, very flexible jointed. Now, it's important to differentiate. You're flexible, but you got versus you got some sort of this thing. So if you're generally flexible, nothing major to worry, and it's much more beneficial to be this thing. But some children can have a lot of symptoms. Then this is what we call as a hypermobility syndrome. And how common it is? 10 to 20% of the population, particularly in the Western countries, much more common in the South Asian population. And now I feel that there's a lot of adult patients who got non-inflammatory, painful conditions like fibromyalgia may have unrecognized hypermobility. That's my take. What causes hypermobility? I won't go into the details. Sometimes it can run in families. Is there a cause for concerns? Now, many children, as I said, hypermobile, they experience no symptoms. They're absolutely fine. And in fact, it's beneficial to perform better than the others. If you look at the current Olympics, especially gymnastics, many of them are hypermobile. But we don't know why some patients tend to have more symptoms, and possibly because of the poor muscle strength, poor muscle stamina, and poor control. And hopefully, I think this will be addressed by Rachna when she does the physio session. Symptoms, this is the most important slide. Many children, as I said, may not complain, but a lot of children can have a lot of problems. Children may take longer to achieve their crawling, walking, what we say is a gross motor development, and they keep bottom shuffling. And by the time they start walking and running, it'll be probably 2.5 years. And some children can be quite clumsy, frequent falls, they're covered in bruises, they're flat-footed, clicky joints, they get tired very easily, they don't want to walk distances, they have pain. And many children who've got a flexible finger joints, they have problems with their coordination, holding a knife and fork, dressing, and also handwriting. So the spectrum is multiple. It's not necessary that the children should have all the symptoms. They can have multiple this thing. Now, this is the spectrum particularly seen in children. Now, I would go to much detail, except you can check yourself when you're sitting there. Now, if you can straighten your little fingers, and if it goes beyond 90 degrees, and also if you can oppose your thumb onto your forearm, and then if you extend your elbows, if it goes more than 10 degrees, again, if you can extend your knees and see if it goes beyond that, clearly indicates that you may be flexible. This is not an easy thing to do unless until you do yoga or if you're very hypermobile. When you do the scoring system, you do score out of 9, so anything more than 5 out of 9. What you call as flexible joints or you're hypermobile. It doesn't mean anything until you've got symptoms. Now, this is some of the pictures. You can see that this child can easily oppose the thumb. You can try yourself and see where it's not easy. And you can see how it can extend the little fingers, and this child has got extended elbow. And now, when you look at these younger children, when they're walking, you can see that this child, the left foot tends to drift outwards. That indicates that the ankles are very flexible. And this child's knee tends to go back like an arch. And this child can do a lot of things which we can't do. And these are things we need to pick up with the assessment so that they can be signposted to the physios, occupational therapists, as well as the orthotic team. Now, a small group of patients can have, in addition to the joint flexibility, they have problems, stretchy skin, they're completely covered in scars. You can see the long-term scar there. And this is a cause for concern where we diagnose whether this patient has got Ehlers-Danlos syndrome. It's a common presentation. And no, they can have a chronic bowel problems, constipation, or IBS-like symptoms, dizziness, what we say is Fort syndrome. These patients need, obviously, the cardiology review, orthopedic input for dislocations, and they need a long-term follow-up. There are 13 types, 12 to 13 types of Ehlers-Danlos syndrome. Most of the types, they have a genetic, you can diagnose some of the genetics, but currently the EDS hypermobility, which is the common type, unfortunately, it doesn't have any genetic this thing. Management, most of the times, I spend a lot of time trying to reassure these families because these patients have been seen by multiple professionals, including the GP, A&E, pediatricians. I spend a lot of time to reassure and taking through the detailed information, and also how to advise them with the management. The most important thing is that they need regular paced activities like swimming, and we listened to the earlier talk on cycling, walking, dancing. All these things is going to help you to improve your stamina and muscle strength, particularly the thigh muscles, the ankle muscles, and what we say is the hip abductors and glute muscles, and these need to be strengthened. This is where the physio comes in. And a number of children, they're flat-footed, the ankles, they have what is known as, they tend to deviate out, and you need ankle support or insoles. And obviously, many children can have handwriting problems. And in fact, we have given supporting letters for the boards to suggest they need some extra time. A very small group of patients may having a chronic pain. I'll miss this. Now, a small group of patients, in spite of all the measures, they end up having a chronic pain. The painkillers are not very effective. So this is where the pain management program based on a sort of a biopsychosocial model comes in place. And my colleague Vasu, he runs a regional chronic pain service here, where he has got the help of the physio OT psychologists, and they run the pediatric psychology-led group sessions for teaching the children and also the families how to cope and distraction strategies, and this is very helpful. And the outcome sometimes is not very easy. Many of these patients have been inactive, the muscles are deconditioned, so they need a very close monitoring, otherwise they end up having to be on a wheelchair. Now, I will be doing slightly injustice if I don't put up this slide. And obesity is an epidemic, and obviously that's gotten much worse during this pandemic. It has got a number of consequences. I won't go into all the details, except you can see that the medical morbidities, high cholesterol, high blood pressure, and Prem, he does see a lot of patients with the non-insulin dependent diabetes in these children. Bone and joint problems is a common presentation of obesity. Now, this is the recommendations from the UK Chief Medical Officer's physical activity guidelines. In children 5 to 18, you need at least 60 minutes per day of moderate activity, and in children less than 5, up to about 3 hours. Okay. Now, this is summary. I think the most important thing is in these children, they need a detailed history, good physical examination, and exclude important causes like trauma, infection, malignancy, etc. And do a relevant investigations. If you try to over-investigate, it ups the anxiety for the children and the families, actually. And the management depends upon the specific cause, as I highlighted. So I'd like to acknowledge all the patients, parents, and carers, and of course my team and the Children's Hospital, my colleagues, including Prem, and the RISE team, of course, for this opportunity. Thanks for having me. And my lovely family, my other half, better half, I'd say, Lena, Jatin, and my lovely daughter, Sonia, was helping with the preparation. Thank you.
Thank you, Shriji. It's really, and I completely agree with you. There is no end to how much we can discuss this and help people with this. The next on line is not many people can match his expertise, and I'm really eager to share, to learn from the pulse of wisdom from Professor Murthy. So next for us is Professor Arumugam Murthy.
Cannot share the slide. Can I able to? And of course, allow me to share, please. Yeah.
மூர்த்தி எதுல லாகின் பண்ணிருக்கீங்க?
நான் internet இதுல, I mean
மொபைலா?
No, laptop. Should be able to. Yeah, can you see or no?
Yeah.
Can you see my slides?
Yeah. On the echo.
Hello. Can you see my slides?
Not yet, Murthy.
Okay.
You should be able to share.
No.
இந்த மூர்த்தி ஷேர் பண்ற முடியுதா இல்லையா?
Hello. I can see my slides. Can you?
No.
You can't see the slides. One second.
நீங்க ரெண்டு ஸ்கிரீன் வச்சு நீங்க ஒன்னு லாக் ஆஃப் பண்ணிட்டு வரங்க.
Want me to go?
I'll share.
Shall we start James then? What do you think?
Yeah.
இல்ல நீங்க ட்ரை பண்ணுங்க நினைக்கிறீங்க.
Was in my Okay, let James go and I'll come back because I don't know why I'm not able to share.
Okay. Thanks, Murthy. Ravi, you give intro for James then.
So James, you've already given intro.
No.
So,
is it?
Yeah, all together.
Yeah, I think we with the technical hitch, we'll start with Dr. James Francis.
Yeah.
Okay. Can you see slides, James? Ravi?
Yeah.
Okay. Thanks a lot for this opportunity. And it's a huge pleasure and privilege to be part of this webinar. Again, musculoskeletal problems in adults is a very vast topic, but I'm just mainly going to touch upon vitamin D and bone health. With bearing in mind the time, in the interest of time, we're going to keep it very brief. I may skim through some slides and skip some slides, so just bear with me. How am I going to move my slides? Sorry. Okay. Just like that. Okay. So generally, I'm going to give you a little. A lot of people have wondered, what does a rheumatologist do? What is rheumatology? So the term rheuma goes back to even to the 1st century AD, and the concept of rheuma is that there is this phlegm-like substance from the brain which flows down into the rest of the body, causing diseases and illnesses. So that's where the term rheuma originates. But it was in 1642, as early as 1642, a French physician, Bayeux, introduced the word rheumatism, and felt that joint pain could be a manifestation of systemic disease. But then it was not until 1949 and 1950 when steroids, this wonder drug, was discovered, and because steroids are very, very useful to treat inflammatory joint conditions, and so that's how rheumatology became more and more prominent as a specialty in its own right. So if you look at the different conditions, I've highlighted a few, but there's a whole host of conditions that we see, that we treat, and it's difficult to cover everything, as you can appreciate. But I thought it might be useful just to make a few distinctions. Osteoarthritis is wear and tear in the joints, where the cartilage of the joints wears away. It can be associated with pain and reduced range of movements. That's osteoarthritis. Osteomalacia is soft bones or bendy bones, and it's usually caused by severe vitamin D deficiency and can often be associated with bone pain. So what's osteoporosis? Osteoporosis is thin bones or breaky bones, and it is commoner with increasing age. It does not cause pain unless associated with fractures. So a lot of people think, oh, osteoporosis, I have pain. No, so osteoporosis, you get pain only when you break your bones. So what is vitamin D? It is a fat-soluble vitamin that is quite essential for human health. It is integral in the regulation of calcium and phosphate metabolism, and is therefore very crucial and vital for musculoskeletal health. But there is also increasing evidence that it may be associated with very many other health outcomes, including cancers, cardiovascular disease, respiratory disease, immune modulation, and infections. So, I mean, this is a busy slide and some of these don't project well, but the take-home message is that those in the northern climes have lower vitamin D deficient levels during all seasons compared to those in the southern parts. So how is vitamin D metabolized? So first of all, 80 to 90% of vitamin D we get from the sunlight, and only about 10 to 20% is from dietary sources. So egg yolk, oily fish, and some fungi have vitamin D, but a lot of it from foods is now through fortified foods and cereals. So the cholesterol in the skin is useful in producing vitamin D, and there's a two-step hydroxylation, one in the liver, one in the kidney, and then there's this interaction between the calcium mobilization between the gut and the bone on one hand, and then there's all the regulation of various cells and also immune modulation. So for example, you have vitamin D receptors called VDRs in almost any tissue. You can see this whole list. So this is where we come to the issue of how vitamin D can be in play in various conditions. And there are various studies showing an association between vitamin D deficiency and colon cancer, hypertension, MI, infection, diabetes, and general mortality. And there's also a high prevalence of why are we interested in this? There's a high prevalence of vitamin D deficiency in Afro-Caribbeans and Asians, and these are data from the UK, saying that a large proportion of South Asians do have low vitamin D. So the various governing bodies have suggested that these are the at-risk groups. So those who are over 65 years of age, children who are under 4 years of age, pregnant and breastfeeding, housebound, those who are darker skin, and who have who are predominantly covering their skin. So these are all groups that are at risk of vitamin D deficiency. So this slide is a busy slide, but it just shows you that those elderly people who have vitamin D deficiency seem to have a longer inpatient hospital stay compared to those who have higher levels. And again, we know that vitamin D deficiency has been associated with increased respiratory infections, and supplementing patients with vitamin D seems to help in this situation. So again, vitamin D deficiency has been found in people in intensive care units, and this to a very high prevalence. And this is again of relevance coming to COVID, which I will touch upon now. So in general, vitamin D is associated. If you have more vitamin D, then you have better bone mineral density. There's a reduction in risk of falls. There's a reduction in risk of fractures, and there's an improvement in muscle strength. So the Royal Osteoporosis Society has graded the levels of vitamin D. So sort of a RAG rating. If you're deficient, and in some cases, if you are, these values are predominantly for our UK laboratories. So if you're anything more than 50 nanomoles is fine for the most of the population. And again, in people who have very low levels, there is recommendation for loading with a higher dose of vitamin D. But in the majority, you can get away with just maintenance therapy. And we usually recommend that, the maintenance therapy in high-risk groups is about 1,000 international units a day in the summer and 2,000 international units in the winter. So again, there's no need to take large doses. If you take large doses, you are likely to end up having a bit of toxicity. So again, there was a mention in May last year saying vitamin D may have a role to play with COVID and its risks, but now we know that there is no convincing evidence that vitamin D itself is in any way directly involved in any morbidity or mortality to do with COVID. So moving quickly on to osteoporosis, to keep it very simple, osteoporosis is fragile bones. There's an increased risk of fractures, and once you fracture, you have more fractures, and it's associated with increased mortality and morbidity. So this is a cartoon of normal bone remodeling. So this cell, this large blue cell, is called an osteoclast. It eats into bone, and then you have these blue cells. These sort of lighter. What color is this? This is more of a whatever. These blue cells, smaller blue cells, they lay down fresh new bone, and then there's a resting phase. And this goes on in cyclically in various bones in the body to variable degrees. So this is normal bone remodeling. So we say that when there's more bone destruction compared to formation of new bone, then the net result is osteoporosis. So this is normal bone, vertebra. And this, you can see the holes there. This is moderate osteoporosis. And then this is what you call severe osteoporosis in an elderly male. So this is an electron microscopic picture of normal and osteoporotic bone. So again, what we know about osteoporosis and the risks, it's really classically, it's the iceberg phenomenon. So we know a little bit about, postmenopausal women being at risk, hormonal status, medications, steroids and things, but genes have a big role to play. So one of the key factors here is peak bone mass. So there are several factors which are in play here, and by the time you're about 20 to 30 years of age, you reach a peak bone mass, and then over a period of time it is being maintained, and eventually there's gradual loss of the bone mass. So steroids, no dose of steroids is safe. Bone loss sets in very early after steroid treatment. So even inhaled steroids can be a problem. So this again, yellow is men in yellow and women in green. So you can see how peak bone mass is reached. There's a phase of consolidation, and then there's gradual loss of bone. And this is postmenopausally, there's a sudden decline in bone mass. So this is a chart showing fracture incidence, women on the left, men on the right. And suffice to know that, you know, there is an increased risk of fractures with increasing age. And here you can see the kyphosis here. This is a lady with arthritis, you can see in the hand. Patient has rheumatoid arthritis. And if you'd x-rayed her back, you can see that she has had a vertebral collapse. So a third of these can go unnoticed and undiagnosed. So the best way to diagnose osteoporosis is through what's called DEXA scanning, dual X-ray absorptiometry. There are many other modalities, but this is very safe. It's very easy, and the radiation exposure is very, very low. And it gives us these figures. It gives us figures comparing our bone density to that of a young adult. And it can be compared to age and sex matched controls as well. And it gives us values. And based on these values, the World Health Organization has classified what is osteoporosis and what is osteopenia and what is normal bone density. Sorry, I'm just skipping through some of the slides. Oops. How do I go back? So here, the correlation between low BMD and hip fracture risk is as good as the correlation between high blood pressure and strokes. That's something to bear in mind. So the aim of us who are treating osteoporosis is to try and assess the risk of fracture and try and address various issues, including lifestyle advice and then therapeutic agents. Exercise is very good. Okay, it improves bone density, it improves muscle mass, reduces the risk of falls, and there is even suggestion that evidence that it prevents fractures. Calcium and vitamin D is very simple, very useful. It is an adjunct, but in very elderly people, this may be all they need. I mean, there are medications that work. For example, these are the osteoclasts, which eat into bone, and the bisphosphonates, which are the commonest drugs we use for osteoporosis, they coat the osteoclastic pit and lead to death and of the osteoclast. So originally, when these drugs came on the market, everybody was with an osteoporosis, with the diagnosis of osteoporosis, was given bisphosphonates. But then we've realized that, you know, these drugs are not as clean as they were thought to be. So we now know that they come with side effects. So there's been a paradigm shift in terms of, you know, from treating it to actually trying to calculate an overall fracture risk. And then if the absolute fracture risk is high, then you treat it. So yes, there is a fracture risk, but, you know, there are ways in which we can try and calculate the fracture risk. Various tools are available, including what's called FRAX, which is devised here in the UK and which is approved by the World Health Organization. So we have the Royal Osteoporosis Society, which it used to be called the National Osteoporosis Society, but now it has the Royal Seal, and this is the main charity which promotes awareness, and so this can be accessed by anybody, and you know, more information about osteoporosis can be obtained from here. I've come to the end of my talk, and I'm just going to see if I can show a couple of little videos here, and then we'll stop with that.
Osteoporosis causes bones to become weak and fragile so that they break easily, even as a result of a minor fall, a sneeze, or a sudden movement. Worldwide, 1 in 3 women and 1 in 5 men aged 50 years or over will suffer from an osteoporotic fracture. A A fracture occurs worldwide every 3 seconds. Fractures caused by osteoporosis can be life-threatening and a major cause of pain and long-term disability. Because osteoporosis is a silent disease with no obvious symptoms, millions of people who are at high risk of fractures remain undiagnosed and untreated.
So what can you do to protect your bone and muscle health?
By taking early action to protect your bone and muscle health, you can set the foundation for a healthy, mobile and independent future. Just follow these 5 basic steps.
1. Exercise regularly.
A combination of weight bearing, muscle strengthening and balance training exercises are best.
2. Ensure a diet rich in bone healthy nutrients.
Ensure a diet that is rich in calcium, protein and other healthy nutrients. Safe exposure to sunshine will also help you to get enough vitamin D.
3. Avoid negative lifestyle habits.
By maintaining a healthy body weight, avoid smoking and excessive drinking.
4. Find out whether you have other risk factors.
To find out whether you have risk factors, take the IOF 1-minute osteoporosis risk test.
5. Get tested and treated if necessary.
Talk to your doctor and ask for testing. If you are at high risk, you may need medication to ensure optimal protection against fracture. Make sure you protect your future mobility and quality of life by taking early action for prevention.
Love your bones. Protect your future.
Getting the right nutrients to build and strengthen your bones may be easier than you think. In fact, you may already be eating many bone-friendly ingredients in your daily diet. Do you recognize any of these? If you are not consuming enough of these foods, start introducing them into your meals, and remember, dairy is a key source of calcium and protein. Fish is a great source of protein and vitamin D, and some fruits and vegetables contain calcium and other nutrients that make your bones smile. No matter what your age, good nutrition helps to keep your skeleton strong and fracture-free. So make sure you eat the right foods and serve up bone strength.
Thank you. I'm going to stop there.
That was very crisp and lovely presentation, James. The videos were very, very informative. I'm sure audience will be really interested to have a look at those again at some point. I think we have been waiting for Professor Arugavamurthy to share his pulse of wisdom with us. Over to Professor Murthy.
James. James, you can stop, then I can start. Stop sharing your slide then. Can you see my slides or not?
I think we still can't see your slides yet.
Okay. Just one second.
Ravi, it'll come in a minute. 1 second.
Yeah.
Can you see now? Can you not see my slides now?
No, not yet.
Because I'm sharing the slides. It's not allowing me to share my slides. Sorry about that. Is it any help from Bala?
You think you can email it to Bala and he can run it from Hub? Anything that can be done?
again?
Bala, you think professor can email it to you and you run it?
I got it now. I'm opening now, Ravi.
Lovely.
My laptop.
Can you see now? One second. Can you see it now, Murthy?
We can see your screen, Bala.
Sure. We can see. Murthy, can you see it?
It's not allowing me to share at all. Bala.
No. Can you see my screen?
I can see the slides, but
Bala, we can see your screen.
Yeah, we can run the slide, Murthy.
Screen. Yeah.
No, you just speak. We can run the slides for you.
No, you need to go into slideshow mode.
Yeah, we are in the slideshow mode.
Bala, open up the presentation so that Murthy can go through the slides. Open up the presentation. Just present yourself from your side.
Sure.
Yeah, that's fine.
Yeah.
Okay. Thank you very much. Apologies for the technical error. It's the first time it happened to me anyway. So thank you, Ravi, for the kind introduction. Thank you for the RISE organizers for inviting me. And it's a great pleasure in coming and giving a talk and updating about the musculoskeletal health problems for our publics and patients. And I must congratulate the organizers for the wonderful effort they are making, promoting the health awareness in the general public. So I'm going to just touch upon joint pains and also some challenges we as an Asian patients facing in this community. And also I'm more happy to take some questions and answers. Next slide, please. To start with, we need to know about what is the joint. I know this is the group of audience predominantly a mixed audience. So for the sake of non-medical audience, I would say the joint is the bones or two bones are connected by some capsules and some tendons, and there is some cartilage in between. This is a simple structure of the joint you keep in mind. This is the joint which is present throughout your body. Next slide, please. So joint pain can be presented with small joints. The next one, click. Or it can be presenting in only one finger joint, or it can be presenting throughout your back or spine, which is back pain. We're going to talk about the joint pain first, and then we go and talk about the inflammatory spinal disease. The next one, please.
Murthy, we can't hear you. Yeah.
Okay. So go back to the previous slide, please, if you don't mind. Sorry about that. Bala, go back into the previous slide.
What is this one?
Yeah. Next one. Yeah. This joint pain can be just present in the small finger joints and also in a bigger joint and also in the spine. The next one, please. So the common arthritis or joint pain is due to a condition called osteoarthritis. Osteo means the joint and arthritis means joint pain. So which is very common. People do call this as wear and tear of the joint. Commonly happen in old age, but that is not true anymore. Now we started seeing very young patients, irrespective of the age. The more you use a particular joint, you get more osteoarthritis quickly. Nowadays, we start seeing youngsters are using text messages all the time, and they may be able to subject to get into osteoarthritis in the finger joints in later part of their life, but earlier than expected. Next one, please. So this joint, if you keep on using the joint, the articular cartilage can get destroyed. This is where the joints will be problematic and it gives you pain because there is a cushion effect on it, which will be lost and that will give you pain. So next slide, please. So how do we manage? How do you manage? What we need to advise you guys is particularly about, go back. So modifiable risk factors, which we also talking about your weight. Weight-bearing joints means if your knee joint is more painful or weight, then reduce the weight which is bearing on that particular joint. And occupation and hobbies which may need to change. Then you may need to address about the pain. How do you manage this particular joint with controlled pain? With simple analgesia, with paracetamol to start with stronger analgesia. Paracetamol is the best analgesia, start using them. And then you start pain relief a little bit and start doing exercise to improve the muscle around the joint to hold the joint. And finally, if it is not improving, that's why Mr. Ravi and team will come and replace the joint. That is joint replacement. So that is the management of osteoarthritis, which is a common arthritis anybody can get. The next one. So the next arthritis, what we talk about is called autoimmune arthritis, which is due to your own immune system fighting against you. We all have an immune system which is there to protect us, whereas the same immune system attacking against us, so the own army fighting against you, that's why you get this arthritis called rheumatoid arthritis, which is commonly happen in the finger joints, but it can also attack other parts of the body like heart, lungs, and skin, even blood vessels can be affected. This is a disease predominantly related with your immune system misbehaving. And we as rheumatologists are very much interested, understanding this condition, want to modulate this immune mechanism by which we can control the disease. Next slide, please. So this is what you see in the joint. When there is an inflammation going on, this is what you get, is a fire. So next slide, please. To understand these joints, arthritis or beginning of any rheumatoid arthritis, etc., you yourself ask the question, is your joints are swollen? Is the joints are stiffened? For example, when you get up in the morning and you're not able to squeeze the toothpaste or not able to brush properly by holding the small joints, and you squeeze your joints, it's very painful. Somebody giving a shake hand to you and it's very painful. These are the conditions. Click some more, please. And this is squeezing the joint. And if you have some skin problem, for example, a condition called psoriasis, and then you get joint pain, then there's also, you need to remember. So general public, what I would like to aware about these S factors. We are not X factor, which is called S factors, which you remember, if you get any joint pain, see is there any swelling. Do see whether there is any stiffness present on the joint. It's in the finger joint. When you squeeze the joint, it is giving more pain or the skin. Click again, please, Bala. Click continuously. And if you take some Brufen, it may get benefit. And bear in mind, if you have some sort of a fever, weight loss, night sweat, or something like that, then you need to seek help. Sometimes people have a very poor sleep pattern. In fact, they have a broken sleep pattern. They also present with more fatigue or tiredness, and also they're presenting with joint pain, which is a condition called fibromyalgia, which is again very common, and we are seeing quite often, even after the post-COVID-19 as a long COVID symptom. Next slide, please. So these joints are swollen on the left ring finger and then the right side also. It may be similar on both hands. That's what it is. This is rheumatoid arthritis. Next slide, please. Next slide. So what we don't want to see anybody getting into this sort of a problem. Nowadays, we see them early and we never allow them to progress into this condition or not even allow them to go. For that, you need to seek help. Next slide, please. Next slide, Bala. Next slide, please.
anti-CCP antibody, Murthy?
Murthy is gone.
Yep.
Yeah, is there? Can you see
it? Years before the onset of disease, and also it will improve. The next slide, keep moving. So X-rays, we don't normally do X-rays. If you're suspecting fracture, we need X-ray. Otherwise, you don't need to have an X-ray to diagnose arthritis. Next slide. So ultrasound, which is the new modality of investigation by which the joints can be scanned. That is a quick test which can tell you what is happening with the joint. The next one. The next one, please. And the next one slide would be, this is what you see, like a redness in your joints. So we need to see them very early. And the next one, please. Next slide, please. Yeah. So we wanted to see them if somebody having joint pain, which is present for more than 3 months with the swelling, particularly in finger joints or feet joints, then the patient need to be seen very quickly in rheumatology department, or you need to seek help with your general practitioner. Next slide, please. We need to see them because we need to confirm this is rheumatoid arthritis, and then we want to treat the treatment as soon as possible, which is the national guidelines now. Next one. The window of opportunity is very, very short. If you can see that, we need to treat you here. Otherwise, the damage is done. So we wanted to see you early so that we don't want it to have any damage to the joint, so that you don't need to end up in orthopedic surgeon for a joint replacement. So joint is very important. Until you don't replace the joint, sometimes it's very difficult. So but we wanted to stop this progression of the disease very early. Next one. Next slide, Bala. Hello.
Murthy, we are moving. Can you see it?
Our internet slow.
Murthy, we can't hear you. The slides are moving, we can't hear you.
Murthy?
Yeah. So we need to, yeah, next one. Yeah. The treatment has become more aggressive treatment nowadays because we start advancing the treatment by giving more powerful treatment. The next one. Next slide. Yeah. We as a rheumatologist or the scientific world is identified lots of targets or the lot of mechanism by which these arthritis are happening. When 20 years ago, there is only few drugs available. Nowadays, there are drugs which is per year cost you £10,000 in United Kingdom per year per patient, which is available. We have nearly more than 1,000 patients in Leicestershire getting this sort of treatment, which completely revolutionized the treatment outcome of this condition called rheumatoid arthritis. Next one. So when you see this sort of fire, we need to switch off. That's what we as a rheumatologist ourselves calling as fireman's son, because we can switch off the fire. And once we switch off the fire, we need to control this arthritis very tightly, which is like diabetes, like blood pressure. We need to have a tight control of the disease, which will control the disease long term. Next slide, please. Yeah, click. So rheumatoid arthritis doesn't need to cripple anymore, because we got lots of conditions, a lot of medication, which we can easily give to the patients, which can control the disease better. The next one. Bala, move. Again, please, next one. So there are some other arthritis, click again, which is particularly with the skin condition called psoriasis, which can affect the joint, which can be a different type of arthritis also due to your autoimmune condition. The next slide is due to gout. which is another condition where it's a common inflammatory condition in male population. Lots of arthritis or autoimmune disease are common in women. However, the lifestyle changes, as you can see this man drinking which is called gout. Next one.
Internet will be slow.
Murthy, we can't hear you.
Internet problem. I think there's a problem with this internet.
Hello?
Yeah, Murthy, yeah.
Okay, so the gout, just go back a couple of slides back, one slide. Yeah, this is a condition due to excess alcohol intake or diet, which is rich in various purines. Next slide. Next slide, please. Okay. Bala, can you?
Yeah, Murthy, we are on low back pain.
Into the lung, but not into the joints, but it is predominantly affecting the joints as well. So if you have rheumatoid arthritis, if you have any arthritic condition, smoking need to be addressed. And also alcohol intake should be reduced as much as they can, because gout is another condition which is very, very commonly associated with alcohol intake. Next one. So then I just to quickly talk about the back pain symptoms, which is one is called mechanical, other one is called inflammatory. I'm not going to talk about any mechanical problem here. The mechanical problem, what we're talking about is predominantly due to if you click your back or lift your something, your back goes. Next slide, please. And this is a disc. On the top is just like a burger, you can imagine. The meat is the middle and the top is the bun. So if the meat comes out, it is due to disc prolapse. We are going to talk about, and various other speakers are going to talk about. Just a couple of slides, move forward, please. Yeah, move forward, move forward. Keep going. Yeah, this is an MRI which can tell you where the disc is, which disc can bulge out. The next one, please. Or it can herniate. It's like a toothpaste, when you squeeze it out, it will come out and it may not be able to put you back. So once you get a chronic back pain, this is due to herniated disc or bulging disc, which is causing these problems. So this for that is usually exercise, which I'm sure other colleagues are going to talk about. I'm not going to touch upon on that one. Next one is, keeps moving, a couple of slides, Bala. Next one. Yeah, it's inflammatory back pain. This is a back pain predominantly due to inflammation in your back of your spine, which is very, very common. However, there is, next slide. Next one. This is a group of conditions which can cause this back pain due to inflammation. The next one, please. So there's a delay of diagnosis up to 8 years in United Kingdom with this back pain, because it happens from age 10 or 12 and up to 40, 55 years. So what is this inflammatory back pain? Next slide. We identified the inflammatory back pain patients are not seeking help. Next one. And even through our study in Facebook, only very few percentage of patients who had inflammatory back pain consulted the GP. That's the reason for delay of diagnosis of this condition up to 8 to 9 years in the United Kingdom. Next one, please. Next one, click. Next one. Next one, yeah. So this is people with less than 40 or 50 years of age. they get a back pain, it is worse when you are resting. For example, when you wake up in the morning, your back is very stiff. And as far as you move, and the back pain will ease us off. This is the pain which is exercise will make it better. This is inflammatory back pain. This also wake you up from sleep because you are lying flat and your back is stiffened, and it also improves with exercise. Any back pain which is better with exercise, present in the morning, first thing in the morning, that is inflammatory back pain. Next one. Well, yeah. So this is what we are interested as a rheumatologist, as I talked to you about. We are not interested in the middle bit. What we are interested in the corner bit, whereby inflammation comes and fuse the joint, thereby you may not be able to bend forward or backward. Yeah, next slide, please. So it also gives symptoms in your heel and also gives some inflammation in your eyes. This is a condition which gets better by taking anti-inflammatory tablets or physiotherapy, but this doesn't work. There's only, next slide, please. Next slide. This is a treatment which you're talking about. This is an MRI showing inflammation in the spine, which is the white stuff in the middle. And if you treat them, a drug which is called adalimumab or biologic treatment, the inflammation which resolve within 3 to 4 months, complete recovery. And it is very expensive treatment, but we are using very, very often now, which is a very good drug, which may help people to get the back pain better. Next one. So next one, please. Next one. Well, yeah. So I'm just touching upon a couple of issues we as an Asian people need to understand about this ethnicity and musculoskeletal health. James has highly alluded about the vitamin D deficiency. I would touch upon this. We are very poor in seeking help. Click that again. Click it again. So there's a significant delay in presentation into primary care. And there is a problem in response with this treatment because people are not taking the treatment properly. Next slide. Next one. So we did a study recently. We identified our patients are not even accepting the high effective treatment. This is a lady who we treated and she refused to take lots of medication. She's only 27 or 28 by the time she had multiple joint replacement. So this can be prevented if the patient's accepting this treatment. Next one. And this even COVID-19 period, we struggled to educate our patients to self-isolations and also medications and monitoring, etc. is a huge problem. Next one. And it is only better if our patient can able to understand and take the ownership of this treatment, which is what we call Apni Jung, which is a video platform is available. If you go and visit on the National Rheumatoid Arthritis Society, which will give you more understanding about this condition for general public. Next one. And our people are believing in a lot of time complementary and alternative medicine rather than understanding about this biologics treatment. Next one. And it is also important, arthritis not only affecting the joint, if there is any chronic inflammation, it may lead on into affect your heart, and people need to understand. So that's why we need to raise this awareness through these sort of meetings will always help. Next one. So delay in seeking help. So please seek help with your clinicians or general practitioner quickly. And if they give some medication, take the medication properly, which is drug adherence. And also accept this is a chronic condition. There's no cure for it. However, we can control it. Unfortunately, there is a cultural and language barrier in treating these patients, which we are trying to address them. And I'm sure these sort of meetings will raise awareness about this condition in general public. Next one. Yeah. So these are the patient charities which you can able to visit, give lots of information like James. Videos can be there as well, you can use. So my message is keep your joint moving, seek help early, and arthritis is not a crippled disease anymore. Next slide. I'm sure you might have understood some of the conditions which you're talking about. What I would suggest to, if you have any sort of a questions or anything which we're more than happy to answer at the end of the session, that's my email and my website. So that. Thank you. And my sincere apologies once again for the technical hinges. Thank you.
Thank you, Professor Murthy. That has been very, very informative. And I think there are a couple of very useful messages for all of us. With all that information, I think the audience has got lots of questions to ask. The floor is open for questions now, and I'll start with the question that was pitched up some time ago, and the panel can answer collectively. The question was, how can we prevent this arthritis, and if yes, how can we do that?
I want to, thanks, Ravi. I just want to come back from the pediatric perspective. Absolutely, there's no diet that can prevent juvenile arthritis, but obviously all the healthy foods, what we say is a 5-a-day or a 7-day, that promotes the growth and development in children is going to help dampen down the inflammation, just like exercise is very helpful in arthritis, both children and adults. It tends to be, there's a lot of studies have clearly shown that it tends to dampen down the inflammation, but there's nothing to prevent. And I'm talking about the foods which are rich in fiber, clean and what we say is plant-based proteins, colorful fruits and veggies, I know what you mean. Herbs and spices, omega-3 rich foods, calcium, vitamin D, all these are quite very helpful in child's growth and development, and it helps to dampen down the inflammation, but there's nothing you can help to prevent or to treat specifically. And the certain things we advise avoid is food which is sugary rich and also saturated and trans fats, artificial ingredients, and also grilled and fatty food. They're not very helpful. So far as evidence is concerned, this is just based on the sort of this thing, but any sort of healthy food that promotes growth and development definitely helps to dampen down the inflammation and makes the child grow and develop keeping pace.
Anything you can add, Dr. Francis, from adults' perspective?
Well, there are studies looking at certain elemental diets, and there is evidence that if you use elemental diets, then the arthritis settles down. But the problem is, being on an elemental diet is not compatible with normal day-to-day living. You can't have an active life. You can sit at home on an elemental diet, which is really not that useful. So in general, we say a Mediterranean diet is supposed to be helpful. If we say that if there are certain foods that make your symptoms worse, then avoid them. Because if you go around, each one will say, avoid this, avoid that food, and then finally you'll end up having nothing to eat. So really, the whole thing is try and be, Mediterranean diet, and if there's anything that upsets you or makes your arthritis or your symptoms worse, then avoid it.
From Professor Murthy's talk, what we learned is we should get the help early and keep the joints moving if you want to prevent worsening of these problems. Anything that you would like to add to answer to this question, Professor Murthy? I think you're on mute, Prof.
He's also having some internet issues, I think.
Okay. Maybe let me move further. From your talk, James, about vitamin D and the population which has moved from tropical countries to UK, they obviously face this significant change in the climate and very less exposure to sunlight. And as you said, most of the vitamin D comes from sunlight. Just to touch up briefly, what would you advise to the people here?
During the summer months, about up to 20 minutes, 15 to 20 minutes of sun exposure, particularly in the morning sun, anytime between, you can go, even if it's best to avoid the very, very hot bit of the thing, but anytime between up to 10, from 7 till, up to 12, 2 o'clock, 3 o'clock is fine. 20 minutes a day in the summer months is enough for us to get the amount of vitamin D we need. And in the winter months, then our bodies will store the vitamin D, and we will be all right through the winter. So if there's really, if you, particularly for vegetarians, where there's really no chance of any vitamin D even through the diet, then during the winter months it may not be a bad idea to take some vitamin D as supplements.
Ravi, I just want to come back on the James' point. Actually, obviously, children, we tend to see vitamin D deficiency is quite common. Almost like 50-60% of patients who come to the pediatric rheumatology clinic, I check the vitamin D levels very routinely, and they are deficient to various levels. The doses we tend to use in children are reasonably high. Up to the age of 3 years, we tend to use about 3,000 units for a period of 8 weeks, and from 3 to 12 years, we use about 6,000 units, and more than 12, we use a very high dose of 10,000 units once daily for a period of 6 to 8 weeks. Although it's a quite high dose for adults, we're not seeing toxicity so far, and followed by maintenance vitamin D supplements. So the Department of Health recommendations, children less than 5, we need 400 international units of vitamin D supplements every day because they are rapidly growing. After 5, you need it only during the winter time. And secondly, the exposure to sunlight, 1 to 2 hours of exposure to sunlight is quite good to get this maintenance vitamin D. And nowadays we are using a very high factor SPF, and that can prevent your the UV absorption. So this is my take on the pediatrics. Doses are slightly higher. Sometimes the GPs hesitate to prescribe, but that's what is needed. And we've not come across any child with a toxicity. Thank you.
Right. With regards to osteoporosis, again coming to James, I've seen people seeking help very late, or they present with fractures rather than any preventive measures being dealt with well in advance. So I've seen the elderly or the postmenopausal women having this problem more so. Would you suggest for the general population as to when they should seek help before it is too late, whether to contact GPs or whether hospitals or whether the rheumatologist?
What is naturally happening is this sort of fracture liaison service is almost every service, every health authority is being encouraged to have a fracture liaison service where we are actively going out into the communities, into the practices, trying to identify those people at risk, because you want to catch them, as you said, you want to catch them really early and before it's too late. Once you've had a fracture, it's already too late. So because fracture begets fracture, so the idea would be to try and develop fracture liaison services, because at the moment the GP services, everybody's stretched. So every time we want to say fractures, we want to bring osteoporosis up, they say no, we have other pressing things on our minds, like cancer and heart disease and those sort of issues. So the idea is to somehow make sort of public awareness. On one hand, you don't want people to get panic stricken, but on the other hand, you don't want to leave it too late. So I think fracture liaison services are the way forward, and nationally this is something that's being addressed.
Right, lovely, thank you. I think Professor Murthy is online now. There's one, probably we still got a time for one more question. Professor Murthy, as you said, early intervention can prevent this massive worsening of rheumatoid arthritis or those horrible deformities which we used to see in pictures. So what should we as a general population should do so that they get early intervention or they get their attention early to these problems in our NHS?
Thank you, Ravi. Patients need to be aware about these simple symptoms. That's what I would remember. I would encourage my patients and publics to remember the yes factor. If they have swelling, they have stiffness, and if this is present there for more than 3 months, then they should, not more than 3 months, earlier they need to seek help. So all these yes they remember, that will tell patients to go and seek the doctor, and the doctor will refer to the rheumatologist. So don't ignore, because people do think I don't get arthritis because I'm young. That's not the myth. That is a myth. So people need to get understanding that we can get arthritis, and we need to get this treated early to prevent joint damage or joint replacement.
Right. I think that I think we have had absolutely informative and very useful session for people. Um, there is obviously a wealth of knowledge from you three, which the general people will benefit. To conclude the session, I would really like to reinforce the points which our eminent authors have pressed on: is regular exercise, good diet, and obviously seek help early. And who better than orthopedic surgeon to tell you to prevent these osteoporotic fractures and these deformed joints? I really don't want to put a knife on those. These are the worst ones. So let's take the take home message: prevent this rather than come to me to fix them. Thank you all of you for your lovely presentations.
Thanks, Ravi, for hosting us, and thanks, RISE team. Thank you. Have a nice evening, all of you. Thank you.
See you all. Thank you.
Hi, Kavi, can you hear me?
You can start now. Yeah, thank you. Srini.
Hello, I'm Muthiala Srinivas, radiology consultant, and I welcome Dr. Prabhu Chalamuthu, who is founder and chief executive officer for a company called Biodime. Apart from running Biodime and actively involved in Biodime, he also has a couple of other companies. So Dr. Prabhu is GP by profession. He also has an MBA, and as I said, he owns a company called Biodime. And there are two aspects to Biodime. One offers a consultation, and then also offers advanced imaging facilities. In addition to this particular company, can you hear me? All right. He also has a management company which basically provides a mediation mentoring role to companies or clients, mainly NHS, if they are in conflicts. So what we thought is to run this as a relatively informal meeting. Some of us may already be entrepreneurs. Some have a desire to know more about this. So I let Dr. Prabhu take over and do a presentation. The questions, we felt that we will do that at the end of this presentation, and we'll see how we proceed. Dr. Prabhu.
Good evening, lovely Srini. Thank you so much for introducing me. And in the first thing I wish to say is what a fantastic podium this is, a virtual podium, to meet all of you, and also to look at such fantastic and very well thought topics. And when I was looking through all that, I was like, my goodness, that's really fantastic way of making people come together and listen and share their experiences. It was fun, I should say. And let me first congratulate the RISE Foundation for organizing this beautiful virtual engagement. I'm happy to be part of it, and I would let's as Srini was mentioning, let's keep this as informal as possible. What I would like to first do is to share my screen and try and let's suss out a few things about what entrepreneurship is. Is it something for us? Is it necessary in our stages of our lives? We are all in different age groups or professions, and perhaps in different countries with different challenges. So we'll touch upon the broad ideas of what entrepreneurship really means for us. And if we are entrepreneurial, and if there is a thought about entrepreneurship, how do we really go about it? And is there any kind of help that is necessary, or is it all about yourself or oneself? So we'll touch a few nerves, as we may say in business parlance, and see where it leads to. So feel free to pose questions. You can stop me as well if you feel that there are some things which you want to know more about. But as Srini mentioned, let's do the first few minutes, a little bit of jigs about what entrepreneurship is, and let us ask ourselves some questions before we interact. So if I think I may be able to share the screen, I suppose. So let me try. Let me get on here. Can you see the screen?
Yeah, we can see it.
Good. So let's, as I said, let's keep this informal. Becoming an entrepreneur, the word itself sometimes makes it very formal, actually. But what is it? These are the two basic questions I suppose every one of us will have. can I become one? What is it? Or am I being too ambitious? These are the two common questions I find. I mean, I myself went through this process, and most of us go through this as well. Can I become one? Am I being too ambitious at my age, at my career level? Will I be successful? And what is this all about? And I think if we look at one question at a time, can I become one, is a very interesting question to see. And when you look at the four primary areas where one can see entrepreneurship skills, if you might say so, is about how passionate one is about something. It can be an idea, it can be an object, it can be something very close to your heart, it can be charity, it can be anything. If you look at it, some of the best ideas which have stemmed from have been an innate process, a process which a person goes through. They find it in their daily lives. They get it from the environments they work in. And they think, see, I really like this and I want to do something about it. And that is where entrepreneurship actually stems from, the passion to do what you really like to do. You know, most of us, I think there was a survey done, and I remember that distinctly when I was in medical school. That survey was projected onto me on the screen. And that survey showed that 80 to 90% of people do mundane tasks, or they just do what they've been told. They're not particularly happy about what they do, but they do it because life has to go. They have to meet their ends, so they just do it. There is a lack of passion perhaps there. And I think that is somewhere people lose track and they just get on with it because life just gets on, it gets busy, children, marriage, or however it is, first, the second, the first. And then you are sucked into such a maze where we really don't have fun and for creativity or some things which you have thought about in your early lives, which you fail to do later on. I think that is where all of it starts. How do we build upon the passion, the root of how this passion could be formulated in a formal setting? In fact, there are questions asked about how much passionate you have to become to become an entrepreneur. Do you really need to be passionate? I mean, why can't be? I'm going to be away from my passionate ideas, but I'll just take something and become, I'll do a business. It can work. I mean, it certainly can work, but would it give you the happiness and the next day to look forward to? It's a question to ask ourselves. So the central theme for any entrepreneur or the entrepreneurship or a partnership is the passion to do things, is to drive one's energy and effort every day, every second. And I think that is where an entrepreneur will succeed to go to the next level. The next level is more, the second bit we put on that slide is the risk taking. Now that's something very odd for people, and especially coming from the health background myself. We are not allowed to take risks. We are always almost told, cut risks. You cannot take that risk. It's impossible. You will not do it because you're going to end up in a big problem. So you are drummed into, from the very first year of your medical school, or for that matter, many of our professions, wherever we come from, risk-taking is not, it's not allowed, or is not somehow, you cannot take risks. I mean, that's basically it. If you do it, then you're going to dig your own graves. Entrepreneurship teaches you the other way. the only way you can sustain a company or a firm or a business is, by definition, is to be risk takers. Without risk taking, a business doesn't go forward at all. So the first point which we mentioned about the passion is one, which is the foundation. But for the foundation to really build upon, you need to take risks. When we talk about risk, what is risk? What is it about risk? Are we going to mortgage all our stuff into one aspect? No, not really. Risk taking is about choosing a path which others haven't really ventured into. And that means that you are going to have a unique position to look up and to formulate your ideas and thought process. So the risk-taking approach is something which an entrepreneur develops. You're not born risk-taker, but I think it comes with experience as well. You can get the risks, and then you always say you manage risk. But the managing risk is one bit, but risk-taking is slightly different to that. It goes one step beyond that. It goes into some uncharted areas. You question, and then you say, I'm going to take that risk. I'm going to invest money in an idea, in a fresh idea. I'm going to get money for this. I'm going to convince the RISE Foundation today that people are going to invest money in me. How am I going to do that? It's going to be all about risk-taking. And that risk-taking approach is something very unique to entrepreneurs. And if that doesn't mean that one cannot be always looking at risk-taking every day in and out, but what it means really is, if there is a problem which comes to you and there are no solutions which you can see, almost always there is a risk you have to take, which is going to be not the linear fashion, but somehow it goes away and then rejoins, or sometimes it can completely go away, but that new path can lead on to different avenues. So the risk-taking approach is something very important for all the entrepreneurs. The third bit, I think, that comes with people and how we mix with people, how good are we with people, and how we establish a network and create friendships. The social skills are very important to be a successful entrepreneur. Sometimes when you are in this modern age where the Zoom platform or other virtual platforms have come in big time, social skills are something which is very pertinent and very important to develop. And as an entrepreneur, one is almost always, if you're successful in managing your people, an entrepreneur is successful in creating the business and creating more profit. So social skills is pertinent in our next stage of an entrepreneurial growth, so as to speak. So we have to have social skills. We have to have managerial skills. We have to understand what the customer says. We have to understand our own staffs. We have to understand our middle management. We need to give them the proper incentives. So these all come from social skills. It's not everything about money. It's about how we interact with people, how we get them motivated. All of that comes through the skill mix of how we can interact with folks. So social skills play a very important role regardless of which industry one is interested in. So that creates, some people are not very social. And what do we do with them? And what can we do about if you naturally feel that you're an introvert, or if you're not a very sociable person, you don't really go out and you don't really mix with people, what can we do about them? There are people who are very successful entrepreneurs who are not socially very outgoing. They seem to take it in, but what they have is the tendency to give forward the points to their next ring of the so to speak, the director board, where that is taken care of. And only then that enterprise can be successful. So social skills and improving upon that is very important. And also, as I said before, in today's internet connective age, this is more important. It takes a little more important, but virtual social skills. How do you virtually connect folks? How do you understand the person virtually? And this is a separate science now in psychology of business. This social skills, which we used to have pre-COVID, is certainly changing the way businesses are getting done. And how do I socially interact with a customer or my own office person or my manager in a virtual setup? So this is an important point for us to look at. An entrepreneur always takes these social skills in very high regard, because there are businesses which break, deals which are made, deals which are broken, deals which go awry, all because of one word not said properly. So it's important to develop this social skills. And the last bit, which I find as somewhere, that's a step which we should say as how to grow business. When we are in the stage of growing business, professionalism is where one's business is going to be different or seen different to others. By professionalism in entrepreneurship, it really means how much you stick to your plan, how much you interact with folks and have a vision and strategy, and then follow it in a rather A to B way. So it's like going from one step to the next step without any issues. So you are sticking to your path, and you are very clear in our ideas and go forward with that zeal and enthusiasm in a very clear way, so that you understand as an entrepreneur and your team understands where we go from. And that professionalism will mark that business to be different, being on time. These are all small things, but if you engage with an enterprise which is professional, the chances are that the customer base will return to us time and again. When we meet their targets, when we meet their timekeeping, when we meet our own schedule and the customer's schedule, this is where our businesses will change the way people's perception towards businesses as well. So professionalism is a key element to be a successful entrepreneur. So in essence, when we look at the 4 bits, if we answer ourselves, one or as a collective group of people, am I passionate? Am I a risk taker, or will my team be risk taking? Will I be socially involved, or will I be socially engaging? And am I professional in my approach? These are the 4 key qualities I believe will set us out to be an entrepreneur. Let's go to the next bits of the question we asked. Am I being too ambitious? Now so let's assume that we have answered the first bit, and now say that yes, I think I may start a business. I think I can do something because of my passion. I want to start off something. This question comes very quickly, because there will be a lot of people putting us into a little bit of here and there situation. They will say, what is he talking about? What nonsense. There's so many people who have done this. They've always had failures, and this is not going to work. It's simply not going to work. And it is a telltale sign that this is going to be a disaster. These naysayers, and there'll be a lot of folks who will doubt you. You might have self-doubts. We all have. Can I sustain this energy? Can I have that zeal all the time? And this question comes, or am I being too ambitious? What is wrong with me? I'm fine being where I am, and why should I do it, become an entrepreneur and get into trouble? There's so many things which goes on in businesses. Am I ready for it? These 4 things is where your ambition is checked or questioned. And more or less, you will have to address this on a daily basis when we set up a business, when you do a startup or you join a successful venture, it doesn't matter. These 4 things always happen in the businesses. Your determination is tested at all times, every time. Everyone questions you. Your stakeholders, your shareholders, folks from your family, your friends. There will be disaster after disaster, failures after failures may come around. And as I was saying to some of my friends, it's just a step away from disaster. Your business is always like that. It's always on a knife edge. People may castigate you. Some things may go wrong. So your determination to keep forward despite all the issues you face every day is what sets out you to be different as an entrepreneur to the others. So if we are more determined to do what we have set out to, and if we have the determination set up inside us at every minute and every second, then you are bound to be creating your own territory or charting your own territory. The second bit is about, very, very important, this one, the impact of failures and what do we do with failures. Any businessman, ask anybody. Businesses are prone to failures. If I run a number to you, out of 100 businesses which come out, I'm talking about the UK, if let's say in the month of June, there were 100 businesses which set out, how many are really successful? And how many really get on to the next quarter or the quarter following? Roughly about 60 to 70% tend to stay for the first quarter. So the concept of even initiating a business is a problem. About 20 to 30% fail at the very initial stage of setting up the business. Why, if we look at it, why is such a high failure rate in the first few months? In the first quarter, when I say a quarter, I'm meaning about 3 to 4 months. What happens there? It is this doubt about what are we going to do. And that's a big issue there. And people go back on their words, or something which is you have planned for has not really taken up. And people question you, you question yourself, and you say, oh, I'm not doing it. I think it's my team is not right. I'm just going to go back. The failures are there at every step, as I said before. So I'm just going to draw the graph a little more after the first quarter, the second quarter, and the third quarter. How many businesses survive out of the 100? About 50% survive the year. So 50% drop off, and another 50% tend to be there. And after 2-3 years, that dwindles down to nearly 10 to 15% successful businesses. The question of success, we will come back at some point, what you determine, what is success. But when we say successful business, just for the argument's sake, a profiteering business. So we are looking at profiteering business of roughly about 15 to 20% maximum in a good, well-performing time of the decade, let's say. That's a positive growth stage. So even in a positive growth stage of the economy, only about 15 to 20% is where businesses tend to make money. So the failures are written all over it. So a business, when we start, this is something which you have to accept in the very first when you start this off, you cannot say I'm going to be successful. Of course, that's going to be the passion which we are going to drive ourselves into, but the failures are the ones which we are going to see day in and out. And how we deal with the failures is what makes us more successful with time. So persistence and determination, as we said before, making sure that determination stands all with you all the time when failures strike in. The third bit is where the planning of growth or strategy, we call that in the nuances of business world, how strategically placed you are, or what is your long-term goals, short-term goals, the vision and the mission of a company and all that comes. But planning the growth is just not you, it's a team exercise. So until this time, when we talked about the impact of failures, it's mostly the individual or the very small group of the directors or partnership. These two are more or less for them. But the planning growth is more of a team exercise. So it's a cause. It's something which we want to look at as a short-term, medium-term, and long-term issue. And then planning growth comes on board when we have the funds, when we have the resources, when we have the team management, and everything comes together, and then we can always discuss in strategy discussion, we call that, and then we can set out plans how to move the company forward or the enterprise forward. And the last but not the least is where it's important for any of our firms or enterprise to be successful is to manage change. Managing change is what determines our marketability or our presence in the market, so to speak, very simply put. If we manage change, we live. If we don't manage change, we die. It's simple. There are innumerable examples, not only in businesses, in our personal lives as well. If people don't change, if we don't improve upon ourselves through knowledge, through self-education, or become a better person personally, or do a different hobby this year, we take up some new challenges. If we don't do that, we don't live from a very uniquely individualistic point of view. And the same applies to businesses. If we don't manage change well, that business is doomed for failure. I was just speaking this afternoon with Srini about a couple of aspects about how businesses, without the knowledge of people are entrepreneurs in themselves. I think Srini will tell us a couple of examples. That there are people who don't understand themselves, but still they are entrepreneurial. It's just that they don't classify themselves that. But one of the key things they do is they manage change effectively. And because they manage change effectively, they become very successful in their businesses. People who closely follow businesses, you will know it has a finite time, unfortunately. Not many businesses survive a few decades, not many, because of many reasons. If you look at the longevity of a business, it's not more than 100 years. So any enterprise, any big enterprise you take, with the same name, that is, they tend not to go beyond a century of 100 years. That's their kind of a lifetime. It may change or may not change with new developments now happening in the last decade or two, and with COVID and all things, maybe some of the businesses may be quite shortened, but some of them will be quite large. But when we say that an enterprise can have a lifespan of 100 years, there is a reason behind it. It's basically because people who started that enterprise had the zeal and enthusiasm, the passion, the hardworkingness, the determination. They had all these ideas of how to make that business grow. They tend to wither away they tend to go away from that business after a certain time because of age and other matters. And then what happens is that business goes to the second generation of folks or to another group of individuals. And almost always the second rung of folks do not have the same zeal and enthusiasm of the first. And so you will see that that business tends to go down and down and down with the time. So to address that, the new businesses, the modern businesses tend to give impetus to manage change. And they have psychologists involved in this. They have external auditors, if so to speak, to come in to the agent, to the firms and give fresh ideas, impartial ideas of what is going on, whether that can be tweaked, whether some things can be changed. People are sent outside of their remit to a different business, so to speak. So it'll be interesting. I'll give you an example, which I always tend to look at, and as an example for people to realize how much it is important to manage change. I don't know. We go to Starbucks, and it's a coffee chain, and it was started in the US, and they. It's an interesting story, but I don't want to go into that too much. But Starbucks was doing well, and the founders were two folks, and they did it well. And to a certain degree, they could expand the Starbucks enterprise very well in the US. But somehow they fell apart due to some reasons. But one of the key problems was they couldn't understand what to do with the new setup of youngsters who are coming into the coffee houses. They didn't simply know how to look at the internet age. How do we do that? How can we change? And they employed somebody coming from outside. So they got some folks, one person who was still running Starbucks. He got some of the folks to come in. And one of the key things they said was, if this enterprise, Starbucks, has to go really forward, the only way it will go forward is for you to make sure that coffee is they don't come for just coffee in your place. They come for an experience, and they come for friendship. So you have to create an environment of friendship there with the baristas. So the baristas, before you walk in, has to know your name. They have to know what kind of coffee you're going to order, and that should be on time. And when you walk in, you get your coffee, you go and sit in the table. You can do whatever you want. Basically, you can work. You can make it as a library, or if you're an office goer, you can work. Or if you just want to grab a coffee and walk away, that also can be done. But if I were to come back again tomorrow to the same Starbucks franchise, the barista will already know what my likings are. And I'm given that extra special treatment where folks understand, oh yeah, so I'm not just a customer, but I am part of Starbucks here, because I'm made feel valued. I'm valued to come into Starbucks. This barista knows that I like this kind of coffee, this cappuccino. This bit changed Starbucks completely. And today they are very successful, whereas this company was to go down 3 decades ago, or rather 2 decades ago. And then now, because of the new ideas and changes they made, they made it so very importantly, they made it as a mission to do that every person who enters the coffee house, they get seen, they get looked after. I think that is what is so important about managing change. When I talk about managing change in business, most of you understand, but that applies to each and every one of us in our profession, in our personal lives. So that is no different to being an entrepreneur. So an entrepreneur has to embrace and manage change. And I'm going to leave that here, and I'm going to throw in, I think, Srini to come in here, and then let us interact. Let's see what you guys think about businesses and what is startup. And I will leave the floor now in terms of to see what kind of questions do you guys have, and how can I be of help in sharing my own experiences.
I would like to thank Prabhu. Prabhu, that was really